to go. Good morning, everyone. Welcome. This is the Cambridgeshire County Council Adults and Health Committee. For those of you in the building, you might be here in Alconbury Weald for the very first time, in which case you're very welcome, and we hope that all of the arrangements around that are working smoothly for you so far, and welcome to all the people that are joining us on the live stream now on the County Council website. Just a reminder that we do allow filming and photography and tweeting. We're very transparent about these things, but please make sure if you do that it doesn't disrupt the proceedings that we're involved with, and can all of us, including me, turn off our mobile phones and put them to vibrate at the very least, please, so we don't get those interruptions. We are being live streamed, and a recording of the meeting will also be available on the County Council's website. This is the bit you're most looking forward to, which is the housekeeping points. If you haven't been in the building before, there are toilets on the corridor to my left, which I'm pointing to at this moment. I do propose to have a comfort break at some point in the morning, as long as we're not behind time. So I don't think we built that in last time, but I will build this in this time, seeing that that's what other committees do, and I think it's sensible. We don't have a planned fire alarm today, so if the fire alarm goes off, it's a real fire. Yes, I'll just take that, yeah?
Yes, just last week when we had a meeting here, it became quite warm, and I did wonder what the CO2 register was. And we did speak to the staff member who can open a door here and through into the air. It might be a good idea to consider that, Mr. Chairman, if we're here. It's quite a long meeting.
Yeah, and I'm looking, that can be arranged. Thank you. If there is a fire alarm, therefore, it really is a real fire, and we all depart through this stairs at the back there, and the muster point is in the green opposite the main entrance. We do have a very full agenda today, so I may be required to stick to the one contribution per item from members on occasions during the course of the morning. And we're also due to have a special meeting now on the reserve date in October, just to look at business planning, budget type issues. So although we've got a paper on the agenda, I intend to take only short questions on that today, because we're going to have a lot of opportunity to discuss that next month, but it is there to give you advance knowledge and information to reflect on in advance of that meeting. So those are the introductory comments. I now move to apologies for absence. Tamar.
So we've received apologies from Councillor Kevin Reynolds, substituted by Councillor Mark Howell. We've also received apologies from Councillor Goldsack. And we've also received apologies from Councillor Jerry Bird. And Councillor Every, the co-opted member from East Cambridgeshire, and Councillor Sam Clark, the co-opted member from Fenland District Council.
Thank you. There is a proposal to have a substitute for Councillor Bird of Councillor Ray, but she's not one of the named substitutes, so we have to suspend standing orders in order to elect her to do that. So I propose that from the chair. Is that seconded? Seconded by Susan. Those in favour of suspending standing orders, please. Those against, please. 6 to 5, so they are suspended. Do we have to also vote on Kathy being the substitute? Yes, we do. Those in favour of Councillor Kathy Ray being the substitute, please show. 3, 4, 5, 6, 7 again. Those against? 1 or half. 1.5, 2.5. Right, that's still passed. Could Councillor Ray come next to Councillor Gay, please? And thank you very much for joining us. We hope you enjoy the meeting. Just give us a few moments while Councillor Ray gets settled. Thank you very much. We move on now to declarations of interest. Does any member wish to declare any disclosable pecuniary interest or non-statutory disclosable interest? There are none. Sorry. Yes, please.
So just for the benefit of everybody to be aware, my wife works in one of the mass vaccination centres. So when we talk about vaccination for COVID, you should be aware of that. Thank you.
Thank you. That was Councillor Wilson. Sorry, I should name people for the live stream as I introduce you. That's my fault, not yours. So thank you very much. Any other declarations of interest that anyone wishes to make? No. Thank you very much. We now move to item 2, the minutes. We're asked to approve the minutes of the meeting on the 24th of June as an accurate record, pages 5 to 22 of the agenda pack. Anything on the accuracy of the minutes first? No, are those agreed? I see lots of nods, that's agreed. Carried unanimously. We then move to the action log, which is on pages 23 to 26. We'd usually note this, but if there are any questions, please don't hesitate to raise them. Okay, it is noted. Item 3, we've got no petitions or public questions that we've received for this particular meeting, so we can move over that item to item 4. So we now move to the first substantive item for our meeting today, which is mandatory vaccinations in care homes update. The report is on page 27 to 36 of the agenda pack, and can I ask Charlotte Black, Director of Adults and Safeguarding, to present the report, please.
Right, good morning, committee. This is, I'm just going to give a very brief introduction to this paper. So this was something that you asked for at our last meeting. The purpose of this paper is to give you an overview of the current situation in relation to mandatory vaccines in care home, for staff in care homes. It's worth saying the national picture is changing on this all the time. So there is currently a consultation out about it also being mandatory in health settings, which was obviously one of the issues and concerns that has been raised. It's fair to say that the position is improving all the time. So CCG staff, public health staff have been working with all our care homes to make sure that any support, any additional access to vaccines or reassurance is available, and that we're confident that uptake is much higher than it was when we wrote this paper. We monitor it on a regular basis and continue to get updates. The other thing that has changed since we wrote this paper is that we've had some clarification, which is that staff who haven't had a vaccination can self-certify a medical exemption for a 12-week period. I think that's really with a view to allowing time for the process in relation to GPs and others who will have to confirm medical exemptions being put in place. So that does give us a bit of flexibility. And the only other thing I would say is that obviously our staff who work in care homes do the most amazing job. We're very aware of that as a result of COVID. And I think it's really important that we appreciate that often people's reasons for not taking up the vaccine are quite complicated and quite deep-seated. And I think it's just understanding that often it is very complex and will require quite a detailed kind of clinical discussion, which we expect will take place when they start seeking medical exemption if they've got particular health concerns. So very happy to answer any questions you may have.
Councillor Wilson, please.
Thank you, Chair, and thank you, Charlotte, for the paper. I think it's very reassuring, all the things that are in there about the work that's going on to help staff see through the issues. My concern is that the paper concentrates on staff who work in care homes rather than people who are caring, who come to individual people's homes. Could you just say a few words on that situation as well, please?
Yeah, we do expect it.
Do you mind taking a note of all the questions?
Of course, certainly,
And then
Chair, yeah.
we'll ask
Yeah,
you to
no
sum
problem.
up at the end, if that's okay.
Yep.
And that's for the other officers just to pre-prepare you. Anything else you wanted to add, Councillor Wilson?
Well, that was the main issue. Obviously, this isn't a fundamental thing for the council to be dealing with. It's really the health service and others and government to sort out some of the arrangements. But it's reassuring the things that the council officers are doing here. Thank you.
Thank you very much. Next, Councillor Bowden, please.
Thank you, Chairman. I had hoped to catch your eye before the debate began because I thought it would be helpful before we have this debate for the numbers which are in this report to be brought up to date, or some indication to be given, because of necessity the numbers in the papers that we have in front of us are quite out of date now, given the time cycle that there is involved in producing papers and publishing them, and I expect and hope that the numbers now are significantly better than they were in this paper. Unfortunately, we will be talking to the numbers in this paper. And I wonder, before speaking further on this, if it's possible for some update to be given to us, because it's important that we speak to the correct numbers rather than speaking to numbers which we've got on our paper. So if some indication could be given before we proceed, I'd be really grateful.
No, I understand that. So could you answer just that point, please?
Yes, certainly. So the way in which we collect this data is we have a tracker which all care homes have to complete and tell us exactly where they are. The last time we looked at the tracker and then followed up with the care homes, actually it wasn't completely up to date. So I don't have a firm figure that I can give you today, but we are going through a process of verifying with all the care homes that have filled in the tracker exactly where they are, and we will be able to provide that information very soon. But the feedback I've got from public health colleagues and others who've been doing the work with the care homes is that they think there are quite a large proportion of staff, since this was written, who have actually made the decision to go for the vaccination.
I'm delighted, Chairman.
Please continue.
Thank you, Chairman. I'm delighted, and I'm not surprised by that, but I'm delighted by it because obviously it will reduce the potential for disruption come November. But what was clear from the report is that we don't have an even position across all care homes in Cambridgeshire. In fact, you wouldn't expect there would be an even position. It was clear from the report that some care homes, particularly one large group that we use, have been way ahead of the game on this and were already at the time of the report ensuring that all staff were vaccinated or had an exemption. My concern is that it's clear from the report that the position across the county is uneven. And my concern is those care homes which are at the bottom of the list, the ones which have the greatest number of staff who, for whatever reason, have not vaccinated. Now, we're now past the date when the first vaccination would need to be taken if they are to have 2 vaccines before the deadline in November. And I didn't get the impression from this report that we were really targeting, in our concern, those particular care homes which did have a particular problem. And my concern was that unless we are targeting them, not merely in terms of trying to ensure that there is greater take-up of vaccination, but also whatever contingency plans may need to be in place, that we find ourselves facing difficulties in November. And whilst it's not us facing the difficulty, but the care home, in many cases, those care homes will be looking after individuals who are being financed by this council. Now, I didn't get the impression from the paper that anything was being done in terms of ensuring that there was some sort of backup plan to be able to stop problems in specific individual care homes where there would be an issue in November. And I very much hope that some assurance can be given to us today that there is such a backup plan and that we could be told what it is. Thank you, Chairman.
Thank you very much. We next have Councillor van der Ven, Vice Chair.
Thank you. I just wanted to ask how much capacity we anticipate will be released through the allowance of self-exemption. And I guess the general question is whether there is confidence that things will be okay. So, how do the numbers add up? And yeah, I guess that builds on Councillor Bowden's question. Thanks.
Any other members? Just some points from me. We've never taken, as a county council, a decision. We looked at it, if you remember last time, on whether we should be for or against mandatory vaccination. We've never done that. And I personally, by the way, I'm torn on it, because I think everyone would say that if we can get this done through encouragement and support, that's better. But I'm also very, very pro-vaccination. So I'm personally torn on it. But there's clearly a perverse consequence if the government's decision to make it mandatory then leads to the sorts of challenges that Councillor Bowden correctly talked about in what you said. I think, Councillor Wilson, we do play a fundamental role. I think it is right to say that although these are independent care homes, they are absolutely part of us delivering our statutory duty. And the people that we're supporting are entirely dependent on those care homes being able to operate. So I think though I understand what you said about the joint responsibility with health, and I fully agree with that as well, I do think we have a fundamental responsibility there. Clearly, the worst thing that could happen is any care home would close because it didn't have the minimum numbers of staff to safely care for its residents, and that would have catastrophic effects. And Susan and I have been in meetings a month and more ago where that was being talked about, not predicted, but talked about, and that we should have the sort of contingency plan that was described in the debate in order to deal with it. And I think the latest things we're hearing both today and in the run-up to today have really reassured me, and I think we should be reassuring the public in Cambridgeshire that a lot of effort has gone in from our staff and from our health colleagues working with homes, and it is all in the report, at an individual level and with lots of materials and counselling the managers. And I would want to congratulate and thank all of our staff who've been responsible for that, because I think it's made and making a real difference on something that could be very, very challenging indeed. And finally, and perhaps Charlotte, you could comment on this, what we know is that the government is now consulting on mandatory vaccination for all care staff. And if it's been challenging for the smaller numbers of staff in relation to care homes, it's going to be even more challenging if this comes in. And I think it's fair to say, if the government's done it for one, I think it's seriously going to think about doing it for all across the health and social care field. And so in order to be as ahead of the curve as possible, I think we should predict that and be thinking about that. I'm sure we are, but I will ask Charlotte to comment that in your answers. Charlotte.
Thank you, Chair. So in relation to the specific questions, I'll just run through them really briefly. So what about people going into people's own homes? Absolutely, that will be covered by the current consultation. Just to reassure you, from a council's perspective, our reablement staff spend all their time going in and out of people's homes. We've had really good uptake amongst our reablement staff. We have very few, if any, I think now, who, other than for medical exemption reasons, haven't taken up the vaccination. So I think there's a strong awareness amongst those staff about the importance of that, but we will have to, the work that we've done in relation to care homes, we will have to do in relation to staff working in the community, which is being really clear about why people haven't taken up the vaccine and targeting those individuals or organisations in a very supportive way, which is the most important thing at this stage, I think. Councillor Bowden, are we targeting care homes that have got a specific problem? We are. So we use the tracker. Emily Smith, who's one of Jyoti's public health consultants, and our care home support team and our contracts team are very aware of those care homes where there is a problem still in terms of vaccination uptake. Those are reducing all the time, and they have very focused discussions in a very coordinated way, and that also includes the infection control staff that work for the CCG. So we are really clear about how we're doing that. It's a bit of a balancing act because those individuals who haven't taken up the vaccine do feel that they've been getting a lot of direction from all sorts of places about the importance of this. So I think it's a sensitive situation that we've got to manage really carefully, but we are making sure that we know where there's a problem and that we're directing our resources in that way. The sort of self-exemption we think does buy us a little bit of time, because actually for many people, and I can think of one specific example where someone genuinely does think that they are medically exempt and they should be, but actually it will only be a conversation with a clinician that will confirm whether their concerns fit with the national criteria for medical exemption. So that's the process that's got to follow. And the question about the current consultation, which isn't just, it's moving on from care home staff to a broader range of health and care staff, is broadly welcome, partly because we have had some people who have made a decision that actually they don't need to get the vaccination, because if they move from social care into the NHS, then it won't be needed. Now, clearly that's not, it's unlikely to be the case if the consultation results in a decision to make it mandatory across all health and care settings, which does seem more equitable. But I think the unknown area for me is still around medical exemptions and how will that process work. And so the next 12 weeks will be quite crucial in terms of monitoring, but we will continue to monitor the situation and ask our care homes to give us regular updates. And at the moment, we don't have any, Councillor van der Ven asked, you know, are we likely to have a problem? We don't have any current care providers that we are concerned won't be able to continue to work and support the people that they support because of this. But it is a challenging environment in terms of workforce generally. So this could be one of several factors, but at the moment we don't think that we've got a critical situation with any of our care providers, and I think they all feel that they've been very well supported by the local authority and the CCG in this sort of challenging situation.
Just one question to come back from Susan. Councillor van der Ven, apologies.
Thanks. Just to round out the picture of protection, for those not vaccinated for whatever reason, is there a testing protocol for daily work?
And Councillor Bowden wanted to come back with a question.
Thank you. Very briefly, Chairman, and thank you for calling me again. I'm very pleased to hear Charlotte's comments about the fact that as far as the Council is concerned, there are no critical issues so far as any individual care home is concerned. But I understand her concern that the next 12 weeks are going to be critical, and who knows what might happen in the meantime. Given how serious the implications could be if one or more care homes do find themselves in a difficult position, would it be appropriate, Chairman, for there to be a brief paper brought to the 14th of October meeting on this subject, just to keep us updated so that we're aware of what's happening? Because the consequences of failure could be very serious indeed, and it doesn't need to be a lengthy paper, it doesn't need to be a long debate, but I think keeping this committee informed would be extremely helpful. Thank you.
Just on that point, as long as you're happy, which I hope you will be, can we put that suggestion in the minutes? There might be different ways, i.e. putting it in a different report, but making sure the information is there. So as long as you're happy with that, we'll minute that and then think of the best way of building it in, if that's okay.
It would be fine, and in fact it depends upon the content of the report. If the report is basically things are still going to be okay, we don't need to worry. If there's if a danger needs to be brought to the attention of the committee, then I think it's appropriate for the committee to be informed in such a way that we can make comment on it.
Indeed. On Councillor van der Ven's point, Charlotte, please.
Yes, there is a very clear testing protocol in place in all our care settings, so that is obviously crucial, and that will continue, but I think for many of those who haven't been vaccinated, I think that they're probably a little bit poised as well to see what will happen next. So I think inevitably, as I say, the next 12 weeks will be crucial, because we're also interested in what action CQC will take as the regulator. But clearly this is mandatory, and it's now law. So thank you.
I think the government's saying that you can self-certificate but not actually have to produce the certificate for a further 11 weeks, which is, I understand, what they've done. Also adds on a bit of time to the 11th of November for people who know how to use that. I hope this debate has fully answered the point. Very fair question. Has help gone to where it's most needed and where there is most vulnerability? I'm absolutely sure that it has. And we've noted the need to come back to the committee on it, but I just want to again assure members that Councillor van der Ven and myself are regularly talking to officers, and this is regularly part of what we're hearing and discussing. So they're definitely will be and is close member contact on this issue, as there should be. As always, I have to read out the recommendations. We are recommended to 1, continue to work closely with adult social care providers to monitor the uptake of vaccines and target support to those settings where vaccination uptake is the lowest. 2, we'll continue to work with Cambridgeshire and Peterborough CCG to ensure that access to vaccines is available for all staff who have yet to take up the vaccine. 3, we'll continue to work with the CCG to promote access to and uptake of the vaccine booster and flu jab. And 4, officers will keep the Adults and Health Committee informed about the impact of mandatory vaccines on staffing levels and on capacity. Are those recommendations agreed? I'm seeing nods. Anyone against? That is unanimously agreed. Thank you very much, and thank you, Charlotte. We now move to item 5. This is use of assistive technology and technology-enabled care, TEC or TAC, in adult social care. The report is on pages 37 to 54 of the agenda pack. And welcome to Grace Clark, the Service Manager for Prevention and Early Intervention, who will be joining us at the table after we've made the COVID-friendly preparations. Grace, you're very welcome at the Adults and Health Committee. And we look forward to you presenting the report.
Hello. Oh, you can all hear me perfect. Thank you very much for having me today and taking time to read through the report that's provided. It's in the pack, I think, pages 37 to 54 to go through. So I'm coming today just to explain to you a little bit about why the technology-enabled care service is important and how it's developed to date. The assistive technology team has been part of the NHS for over 20 years, and around 5 years ago it was amalgamated with the council, resulting in the current joint-funded technology-enabled care service we have today. As part of the Adults Positive Challenge programme, the service was developed further with a change for the organisation to a tech-first approach that can calculate cost avoidance through an outcome-based model. Tech can range from simple prompts and reminders to more advanced sensors and activity monitoring. Last year, the service developed even further to become our own provider of lifeline support, and this is 24 hours a day through a lifeline button. This provides a more rounded service and provision for its users. It can link us to other social care services. It gives us early detection of increased need, so people are no longer having to contact us. We can predict their needs, and also non-emergency support for people. The service as a total is becoming more well known within the tech industry. We've been asked to provide guest speeches recently, and we've recently been shortlisted for an LGC award as well. The team work very closely with our partners, including the Clinical Commissioning Group, Cambridgeshire and Peterborough Foundation Trust, and also our local universities, and we're also part of a development of an innovation hub within Cambridgeshire. Cambridgeshire itself is one of only 17% of local authorities who are registered with the Tech Services Association and are a dedicated tech provider. One thing the pandemic, I think, has really shown us all is how technology can be a huge benefit to people, especially when you can't see people face to face. In 2020 to 2021, 43% of tech interventions were for those aged 65 to 84 and 40% for those aged 85 plus. As someone who taught my 83-year-old grandmother over the phone, I'd like to add how to download Skype on her iPad and make a video call to see her first ever great-grandchild during the pandemic. I can tell you that technology is not just for the young anymore, and actually it's becoming more well known to all of us. And really it's down to us as a local authority and practitioners to change the perception of what support is and how it can be delivered and who to. It's really about changing the narrative. So if I'd have told my husband at age 30 he needed a falls detector, he would have laughed me out the room. However, when he found an exercise watch that can report back to me when he's fallen off his bike and call the 999 services, he bought it instantly. So really it's about us as a team making sure that people are empowered with the correct knowledge to find the equipment that they need and works for them. Equally, tech won't be suitable for everybody. And this is where the team work very closely with the person or their representative to look at what outcomes it is that they want to achieve and review any inputs to ensure it meets their need. A recent ADAS report found where technology is used to support people, they have better outcomes. And tech's not just about saving money, as much as we all do like to save a little bit of money. A tech intervention can bring about cost savings, but actually a switch to a tech-first approach sees a move more towards outcome-based approach and a focus on early prevention, which ultimately results in a delay in the need for formal services and more control and independence for the user. Most people would prefer a piece of technology rather than someone intruding into their lives. Last year, tech interventions were able to support over 1,000 carers and over 600 people to manage their health conditions. So how do we ensure that we continue to grow the service, putting Cambridgeshire and its residents at the forefront of the digital revolution? You'll see in the paper a number of suggested future developments with a focus on increased communication and education, earlier support, and a carers focus with ongoing promotion and expansion of the service. Updating our smart flat and opening this to the public will allow for residents to not only learn of new equipment, but to see this in action and receive specialist advice and information. The team are looking closely at Telford and Dorset councils who currently lead in this area. Service expansion will include promotion of the service to ensure widespread knowledge and ability to meet growing need, as well as trials of new services such as outbound calling, which can provide support on needs not met by Care Act assessments. So as we move forward into 2022, our hope is that everyone can have access to technology, be it a one-cup coffee machine to help start your day, a GPS watch so that you continue to do your walks that you love every day, or a robotic cat to help you stop feeling lonely at home. Thank you very much.
Thank you very much. And I love the story of your great-grandmother. We've probably all got some experiences like that, but it makes a good point. Councillor Daunton is first, please.
Yes, thank you. Thank you very much, Charlotte, for a well-presented paper and some good stories. You mentioned during the course of your presentation they work with universities, and I just wonder if we are already working with Professor John Clarkson in the University of Cambridge and his Engineering Design Centre.
That's not a name that's been...
Again, would you mind just taking note of the questions? If there's one that needs an immediate answer for response, as we had in the first debate, I will take it. But otherwise, if you could just take a note of the questions and deal with them all at the end, I'd be really grateful. Did you want to add anything? Sorry, did you want to add anything?
No, thank you, that's fine.
Lovely. The next one is Councillor Slatter, please.
Thank you very much for that paper. It's a subject very close to my heart. There was a time when I was combining being a city councillor with being a bowel care nurse for people with MS, spinal injuries and so on. An interesting combination of jobs. Now, as I say, it's very close to my heart. I'm delighted to see it on the agenda. Well done on being leaders in this. I can lay claim to at least two of the amazing engineers in my ward. You will have come across Toby Churchill, inventing the light writer, and Dan Everard and his drag mobility. I make those points because often our talent is alerted to the need by the needs of family and friends, and so often our volunteers are as well. But I also know that the inventors are a restless bunch, and they do tend to keep bringing out something new. And I know we are supporting everybody going to conferences and exhibitions and sales, in fact. But I would also hope, given that we know that's expensive, and if we have to keep renewing equipment, partly because children, I'm glad you mentioned children, and we must mention them here as well in the adult committee, they often have to have things adapted simply because they're getting larger. So not only children will be difficult to predict as an expense, and so I'm just a little bit concerned that we should always make sure there is the Zimmer frame and it's never been bettered, and that can also make a great difference in the way of enablement, and it's an assisted technology as well. I'm very pleased with this, by the way. Have you all got a copy of that? No? Oh, please get one. They're in your local library. A Guide to Independent Living in Cambridgeshire. It's a really good collection. And if you are guiding somebody, not on the phone, it's really useful to have some pieces of paper. But I didn't see any reference in the huddles or anywhere else, I didn't think, perhaps related to Councillor Daunton's question, as to whether we're making full use of REMAP. It may well be associated with the work of Dr. Clarkson, I don't know that name, but I did contact them yesterday just to see how they were placed, and REMAP Cambridge has had an upsurge of volunteers and not of referrals. REMAP, if you're not aware, are engineers and other associated scientists, but mainly engineers, who volunteer their time and skill to make bespoke gadgets. And that can make a big difference. It enabled a patient of mine just to go on holiday because he could call with a bell just by moving his head. That's not the sort of thing you expect in a hotel, but he could take it with him. So I am obviously, in that case, trying to save a little money, but also to employ the talents that we have locally and spread them out back to Dorset. Let's not be beaten by Dorset. I think that was all I was going to say. But as I say, it is hard to predict, and we'll probably see something in the business planning for this excellent initiative of yours. And thank you very much.
Thank you. And we'll see if we're going to have a digital Zimmer frame in the next phase following that question. I'm not sure what you've got against Dorset, but anyway, perhaps we haven't got too many people watching from Dorset. Councillor van der Ven.
Thank you. Thank you very much for the report. And I wanted to take the opportunity to thank particularly the sensory impairment team, which I was delighted to visit a couple of years ago before the pandemic, and witnessed both through staff and through users the amazing confidence that they were able to provide, not just confidence, but actually joy. And I wondered if during the pandemic, the in-person training and you know, the learning, getting to grips with technology has been possible where needed, and whether that service has been able to keep up, you know, with the really important work that it needs to do. Thanks.
Thank you very much. Councillor Bowden.
Thank you, Chairman. We are not at the forefront of technology-enabled care. It's mentioned in the report. There are other local authorities which have gone before us and gone further, other ones including some which aren't mentioned in the report. And that's not necessarily been a bad thing, because we've had the opportunity to learn from some of the dead ends that some other authorities have gone down, and so I'm not going to be critical of that fact. However, I very much welcome the report, and I very much welcome the presentation which was given. Thank you very much indeed. But at the beginning of the presentation, there was a very interesting comment that was made, and that was that it was mentioned that this provides cost avoidance through an outcome-based model. And I think that needs to be deconstructed so that we can change it into plain English, because when we put it into plain English, I think it really comes to the nub of the issue. The first is, we talk about through an outcome-based model. And that relates to the fact that this actually provides better care for many individuals in many circumstances. It's measurable better care, measurable better outcomes for many individuals in many circumstances. And that must be what the care system, and what, for that matter, the health system, should be primarily about. So it's really important that we recognise that the rather dry phrase outcome-based model actually means something in reality to individuals, and is very important and very much to be welcomed. The second part, talking about cost avoidance, and I put that second rather than first, is also important, because we have to be aware that there are limited finances available for this council and for the system as a whole. And anything which does produce cost avoidance allows us to spend less money so that we can concentrate our resources more widely as we need to, is to be welcomed as well. And when you have this combination of an improved outcome together with a reduction in cost, that is something which doesn't very often happen in the system as a whole, and it is absolutely endemic within technology-enabled care that this is an outcome which is available. So it is very, very much to be welcomed, and I think that it was important to put that into plain English rather than to use the more technical phrase which was used in the presentation. But we talk about cost avoidance, and we as a committee may be particularly concerned, of course, about cost avoidance to the county council. And there is cost avoidance to the county council through technology-enabled care. It does mean sometimes that there is an upfront cost which has to be borne, but that is very, very quickly repaid in terms of the reduction in overall costs that we have over the lifetime of any particular equipment. Forgetting about the fact that we've got improvement in outcome as well. So that is very much to be welcomed. However, it's not just on the care side that there is cost avoidance. The use of technology-enabled care also allows cost avoidance and significant cost avoidance in the hospital sector, particularly on the health side. And it is really a very significant preventative measure which can be taken in order to reduce costs across the whole of the system, not merely on the care side, but also on the health side. Now, the CCG does contribute, does assist with this, as we know, but I'm not sure that we are getting a fair balance here between the amount of cost which is being met by the county council and the amount of cost which is being met by the health side of things. And it's been my experience on the health side that they are not as responsive to making expenditure decisions for preventative measures as they are in being responsive to illness or injury. And I just wonder whether we need to press further with the CCG in ensuring that there are additional resources made available from the health side to reflect the amount of cost avoidance that there will be in the health system as a result of us taking this up further. I wouldn't want the overall benefits to be gained by the individuals concerned and by the system as a whole to be constrained by an inappropriate lack of resources. And it seems to me that the health service should be less short-sighted and be more willing to fund preventative measures such as this than they are now. And I fully accept that they are making contribution, but I just wonder whether they're making a fair contribution based on the benefit that they get. And the more money, to be quite honest, that we can put into preventative care and to technology-enabled care such as this, the better as far as I'm concerned. I think there's a long way to go, and there's a lot of further advantage still to be had, and I would hate resources to be a limiting factor in this. Thank you.
On that last point about the CCG putting in more resources, I think that applies to a number of areas, not just to this area, but certainly this area would be included in that, and I was envisaged that issue coming back to this committee for review in a broader way at a future time. Our next speaker is Councillor Wilson, please.
Thank you, Chair. And I agree entirely with what Councillor Bowden has said about getting more money from the health service to help us do more work on this. There's some excellent initiatives going on here which we need to encourage. I've just got two specific comments. One, there's reference to a smart flat which is going to be revamped, and when it has been revamped, I would welcome the opportunity for some of us to go and have a look at it and see with Philippa to see what opportunities there are. And a couple of weeks ago at a gala day in the town where I live, we had a stand which had got a lot of leaflets about scam awareness, and that went down extremely well with members of the public. So two comments. One, to what extent are you working with scam awareness colleagues in the County Council? And secondly, is there some sort of roadshow that we could take out to, or you could take out to public events where we could promote this sort of work? Thank you.
Lots of good ideas this morning. Thank you, Councillor Wilson. Councillor Hay, please.
Thank you, Chair. I'm sure there's a large number in the general public that struggle every day just to do everyday things. What are we actually doing to get the message out there that there are things that can be done to help them? Because I'm sure if you mention technology-enabled care to a lot of people in the general public, they wouldn't have a clue as to what that meant.
Very fair question. Councillor Dupre, please.
Thank you. I thought this was an absolutely excellent report, and I loved the case studies which really brought all of this to life, and I loved the presentation as well, so thank you. Just a very quick question about the role of social housing providers in supporting technology and installation of technology where installation is required. Thank you.
Thank you. We have Councillor Howell, please.
Thank you, Chairman. Big fan of assisted technology, worked with it since the mid-80s when I was involved, very limited, with Professor Heinz Wolff, who turned to Freud's bioengineering, so big fan of it. How do we square the ethics of putting what can only be described as a tag on somebody who may have some form of dementia? This system has been around for a while for tracking and different things like that of people who have been released early from prison. But how do we do that with regards to somebody else who does a family permission or whatever? Thank you, Chairman.
Thank you. A few comments from myself. I really welcome this report. I think it is fair, and it's good in the report that there's that section about the people it isn't right for, and what you said earlier, Grace, because I think, let's face it, a lot of the people with whom we work are isolated, they're lonely, and it's a human being that they want to see more of rather than a machine, and I think we should remember that. Nevertheless, it's quite clear that this is a really interesting part of our toolkit, and probably a growing one, certainly if we agree the recommendations from today. I really like the points made by several people, and also made in your introduction, Grace, that this is about the quality of people's lives first and saving money second. And yeah, I think that's a very, very important point for us to make. Although we might not be absolutely top of the list, Councillor Bowden, I think the report says that there are only 17% of local authorities that are currently registered as providers, and we're one of only 17 again, that with a overt tech strategy. So I think we're pretty much leaders in relation to this, and I welcome that as a good thing. And the fact that we're shortlisted for the LGA Awards is fantastic, and good luck. Hope we win. Like Councillor Dupre, I loved the case studies, and this is true of some of the other reports today, by the way, but I think the case studies really make life and truth to the concepts in reports, and that's very, very much true with this one as well. And just in terms of this being part of enhanced response, about 2,000 people across Cambridgeshire didn't go to hospital last year that would have done. That certainly was a statistic and a figure that struck me when I read this. And I think if we all think about that of our own loved ones, you know, that's something that really underlines the importance of supporting this approach. Lots of contributions. So, Grace, can I invite you to reply to what you've heard, please?
Yes, of course. So sort of starting with regards to the universities, it's not a name that I recognise, I have to say, but what I will say is the team manager for the team has left recently and I've started taking things over, so it might be that it's just a name I don't know. But certainly we have joined part of the Innovation Hub and they're only just setting up. So what I will do at the next meeting, I'll suggest if we're not already involved with remap and things, we'll try and involve people in that Innovation Hub, because it's really looking at how we can bring new innovations in and share them across Cambridgeshire, really. So I will recommend that where possible. We're also looking to connect back with the local universities, especially Anglia Ruskin University as well, so that when they're doing their social care teaching programmes and things like that, we try and put bits in about tech as well, because I know they're not things that are currently always thought about.
I'm really bad at names, and I am learning them. I do promise I am. Councillor Daunton wanted to come back.
Thank you, Chair. I'm very happy to, outside the meeting by email, to put you in touch with Professor John Clarkson, who works specifically in assisted technology and has strong links with public health. So very happy to do that.
I would very much appreciate that. Thank you.
Please carry on.
And then with regards to sensory and really the teams and how they work. So the tech team continued throughout all the pandemic. So they've been going out, they've been installing essential equipment throughout all the pandemic. We held off on some of our more activity monitoring if we didn't feel it was urgent earlier last year, but we are back doing everything. The sensory team in the first lockdown stopped doing face-to-face, but were able to provide most things over video calls actually. And we had some really good case studies that went out, media, of how they've used Alexa and things like that to support people. So I know there was a lady who recently became blind and they taught her how to make her bed over the FaceTime, which actually was one of those things that I thought, as much as I hate to make my bed every day, I couldn't imagine not being able to see it and how to do it. And they just taught her how to redo that, and it just changed everything for her, which I think shows how much sensory impairment. They are now back doing face-to-face with everything. The only things they're maybe not doing is transporting people in their cars. But other than that, they're back doing all face-to-face visits. With regards to the outcome-based model and cost avoidance, I appreciate that, sometimes it's using the wording, and in there it does sort of break down. And I think actually when you look at it, that last year 3.66 million was saved. It's a huge figure really that does show how much of a difference it makes. But for me, I also think it's really those outcomes where there isn't a cost saving as well that are so important. So it's those carers, that hospital prevention. And that is something that to date we've been unable to get cost savings attributed to, because it's difficult for the CCG to work out how much hospital prevention would cost and things like that. But it is something I would quite like to work on, because it's certainly, the numbers are there. We are currently looking at our Section 75 agreement anyway with the CCG, so I just wanted to assure you with that as well. And also just to say, our Lifeline service as well does also bring cost into the local authority. But I think the thing for me is not only does it bring cost in, but it is such a more rounded service of Lifeline provider for people. So it's a little bit of a win for us, but actually it's so much better for the individual as well. With regards to the smart flat, very happy to have people come along, and what I'd really like to do is open it up to the public. I'm actually meeting with Chorus next week, because it's them that own the property and have always let us use it. So it's actually just working out the technicalities of how do we update it, the cost of doing that, and also is it safe for us to be having people in.
If you finish, and then if there is a further question, I'll come back.
So we are going to be looking at that, and I'm trying to move that forward. With regards to scam awareness, we do work quite closely with them, and we've had meetings with them recently, because I know a lot of the things they do is like put blocks on telephone lines, and it's how that works with the Lifeline service, because we want to make sure people's Lifeline calls are still going through. At the moment, promotion-wise, we always used to go out, we gave multiple talks, we did things like that as a service. Because of the sheer demand on the service at the moment and capacity, we haven't been able to do that, but we're looking to restart. But certainly at the moment, think communities, when they've got the bus that goes round, we're trying to teach them about tech, give them some information and things as well, which sort of leads into how do we tell the public about us. So every year at Christmas, we post out a Christmas wish list to everybody. And really that's about technology that you might consider just using in your life without even thinking about it. So like the 1-cup coffee machine if you can't lift the kettle, things like that. So we put those out at Christmas. We also put them out during the pandemic, and they go out on sort of Facebook, Twitter, things like that. We're also really trying to, so what our plan is to actually market the team better. So everybody loves the case studies, and everybody loves when we can show people how things are doing. So what we'd really like to do is work with families to sort of video their experience and get that out to people, because it makes it so much more personal, and then people understand it. We're also doing a lot of work on the website and how we can get that information out as well, and just how we can get information out. It's just been because of demand at the moment, we haven't been promoting ourselves because we've been struggling with the capacity as is, but it is something we're looking to do going forward. With regards to social housing providers, as I say, we already work with Chorus, who own our smart flat. The difficulty with social housing providers is a lot of them have their own lifelines or call bell systems in place. And a lot of the time, a lot of the equipment and peripherals that are needed don't always fit into their call bell systems. So we're working with them to try and see where we can add our technology on, we will. And if not, a lot of them now will work with us so that we can put our lifelines in so that people can get more peripherals like the linked smoke detectors, bed alarms, falls alarms linking to their lifeline. So we do work with them on that. We are also trying to encourage local social housing providers as well to think about the digital switchover that's coming in 2025. We as a council are very prepared for the digital switchover and have digital solutions already. We know lots of social care housing providers aren't maybe as advanced as us in that, so it's just trying to prepare them where possible. With regards to the ethics, especially around GPS tracking, so anybody that is referred to us where we have concerns about their capacity, we would ask that any professional involved does a capacity assessment with them and also considers around whether that is a deprivation of liberty for that person. So we would expect a full capacity assessment to be done. We would expect a full best interest decision to be done. What we also try and encourage people is actually at earlier stages to have those conversations. So while somebody still has capacity, having those conversations as to how would you feel about GPS tracking. One of the things as well as a council that we very much push is activity monitoring, not cameras. So yes, the activity monitoring might be able to tell that someone's moved from room to room and that a door's been opened and things like that. It will not film the person. And we do very much talk to families as well, because we know families quite often put cameras in, and we very are clear with them that that isn't something we would always support, but if that is something they do, we'll support them with doing the capacity assessments and looking at the deprivation of liberty around that. So it is something we're very clear about. And just a note with regards to the Enhanced Response Service and the Lifeline, I guess for me, that is one of the things that people really do love about our Lifeline service, and that is what sells our Lifeline service. Because for so many people, and I think for lots of us, our families would love to come if something happened. They can't always make it. And actually the Enhanced Response team are just there and can go out and support somebody. So just yesterday we had somebody, we couldn't get hold of the gentleman, his phone was turned off, we weren't sure what was going on, family couldn't get hold of him either, they lived 2 hours away. The Enhanced Response team went round, turns out he couldn't find the charger to his phone, they helped him find it, they set it up, but we knew he was safe. It meant that the family didn't call an ambulance that wasn't needed.
Thank you very much indeed. Councillor Swatter had one follow-up.
Quick one. I mentioned those huddle groups and whether they included REMAP, but also I don't know how many of the district councils have an access officer. I know the City Council has an excellent one, and I certainly, when I was on the planning committee, I used to go around with him on site visits, enabling the hotels to be hospitable. I realise that's not our job, Mr. Chairman, I'm not suggesting, but on the other hand, that was a useful aspect. But I would hope that you invite these officers, if there are any more, to come to that smart flat, maybe even before it's finished. Because it's so annoying when somebody says, oh, you haven't got a so-and-so, and you bought... This is the trouble about these restless inventors, you know, they are the very devil, because they seem to be bringing new stuff on. And also getting the word out. Take your point about the connectors. I was hoping to see them this afternoon in my ward, but I'm here. Are the social prescribers as well? I know it's all in here, the connections, but you know, the more we join everybody up, the better, and get that word out. Finally, people's families' abilities change. We had a lifeline, but we used to go out and do the lifting with our own Elcama lift. When my husband and I got a bit old to do that for my mother, I was so glad of the system where 2 more able-bodied people came in. So I think we need to make sure that people can come back to us if their needs have changed. Usually it means they've got greater, but I think we do need, it's all good prevention. Thank you.
Okay, I think those were for noting rather than reply, but all good and strong points. So thank you very much for that. Thank you, Grace, for a really excellent presentation and set of answers. I like the 1 cup coffee because I think that, again, makes the point that this isn't about replacing or substituting vital care. It's about enhancing people's quality of life. So that's a great example as well. If the remap point could go in the minutes, and also Grace's point about its activities, not cameras, which I think was a really important point that you made, then I'll be very grateful for that. We all want to go to the flat when it's COVID safe to do so, and providing it is accessible, quite right. And it's also very Councillor Wilson's point about publicity. It may well be that other partners, not least ourselves, can use materials if they're made available to us. So I would encourage that alongside the work with Think Communities. And it's quite clear listening to the Councillor Dalton, Howell and Slatter, who all have expertise in their divisions and personally know testers and innovators and scientists that have behind this technology, that there's a lot of expertise in the committee about it. Wasn't Hans Wolf on the television for a lot of my childhood? Have I remembered that correctly? So I got a nod from Councillor Howell on that. So it's very nice that he's made an appearance in 2021 in the Adults and Health Committee. Thank you for raising that, and it's interesting that you know him personally. So our recommendations are to note the findings of this report and to consider the opportunities, as we have done, to expand and develop the tech service, and ask for further work to be taken forward within the business planning context. Are those recommendations agreed? Again, I'm seeing nods all around the room. Anyone against? No, that's again agreed unanimously. Thank you very much indeed. We now move to item 6, perhaps a more challenging one in a different way than the last item, and this is social care reform. I think it's fair to say that this is a very initial look at this issue. It's a big issue, and I think we'll be coming back to it to have a much more in-depth discussion at later times. But with thanks to the officers, we thought it was important to have at least an initial chance to exchange views about this, because it is so important. And I'm extremely grateful that at very short notice the officers did manage to pull this report together. So it's Will who is going to... Is it Will? It is Will, yes. Will Patton, who's going to... Sorry, I was going to shock you by asking someone else to do it. Sorry, Will. And you did pull this together. So many, many thanks for what you did, and I invite you to speak to the committee.
Thank you. And good morning, everyone. So I will just start by saying that this is a very early initial view, and there's likely to be many more questions than answers. So, but we did think it was important that we give an early indication and some thoughts around the announcement that was made on the 7th of September, where the government announced proposals for social care reform. And like I say, this paper gives a very early overview of some of the potential impacts of that. Just as a quick recap, the announcement included a £36 billion fund allocated to health and social care over a 3-year period, raised through a 1.25% increase in national insurance contributions. That the priority for the 3 years is to tackle COVID backlogs, to implement the adult social care reforms, which I'll come on to in a moment, and to bring health and social care together on a long-term sustainable footing. It's understood that 5.4 billion of the 36 billion will be made available to social care to implement the reforms. We don't yet know the detail of that, and nor do we know the local allocation, what Cambridgeshire's allocation will be. In terms of the reform, what we do know is that it includes a lifetime care cap on costs, and that's to be introduced from October 2023 and be universally applied to all. So, so that includes those who currently pay for their own care, the exception being those with assets under £20,000. People with assets of between 20,000 and 100,000 will be means tested on a sliding scale, but again, we haven't seen the detail of that. And then the other key area is that people who currently pay for their care can turn to the local authority to arrange care on their behalf on the premise that the local authority can source better value care than themselves. We do anticipate that when we get into the detail, the reforms will bring significant change, and change to the individuals who need support, but also to the organisations that provide support, as well as the local authority. And as those details emerge, we will obviously be working to get a clearer picture of what those changes are like and scale of those changes are like to involve. The only other thing I would add to this is, as we stand, it's worth noting that the announcement is silent on supporting social care to meet current pressures and increased needs, as well as meeting the increased demand and unmet need that will result from focusing on catching up with the COVID backlog. It's also unlikely that some people, particularly older people, will breach the cap, particularly as it's to be based on care and not accommodation costs as it is today. And more detailed work is required to understand the full impact of that. It's likely that many more people will be eligible for support from the local authority, given the changes in the lower eligibility values. And this in turn will of course increase demand, and it will also increase demand on our social workers and our assessment teams. And then finally, it's silent on the pressure that it will place on our providers of care and the care staff as a result of increase in things like national insurance contributions. So, as I said in my introduction, I'm sure there'll be many more questions and answers, I'm afraid, but can assure the committee that as details are released, we will work to understand the scale, the consequence and scale of those, and keep the committee updated.
Thank you very much again for that, and thanks for the presentation. Councillor van der Ven.
Thank you. Thank you very much for providing this paper at, in a constrained amount of time. And as you say, there are more questions than anything. The overview provided in the paper lists the tackling of COVID backlogs first. And given the fact that the COVID backlog in and of itself is a crisis, I guess that the worry is whether this initiative will be of benefit to the people who need much more support, and to this council and its responsibilities. There's a particular concern on new burdens for younger people, and what that long-term impact will be, and how do we get to grips with scoping that out now. So I'm sure we all look forward to more information. I would maybe just add that this world is already distressingly complex, and as a councillor, I'm always aware of the navigation that people need to go through to find the support that they need, and the bewildering nature of it all will remain, I would imagine. So yeah, thank you again for the report, and I'll look forward to the other questions.
Thank you, Councillor van der Ven. Councillor Bowden.
Thank you, Chairman. And thank you also for ensuring that this report did come to us at very short notice. And I was very pleased with just how factual and how unbiased this report is. Absolutely straight down the line. And I hope that we in this meeting will manage to take party politics out of this, if only because I'm going to say quite a few critical things about what is being proposed at the moment. But it's not, the party politics isn't important here, it's the outcomes which are important, and the outcomes for our residents. And I think that we all need to have those utmost in our mind when we are discussing all of the implications here. And yes, there are lots more questions than answers, but the first thing is, we've heard for at least 25 years, and some people will have more experience than I have and can go back further, but for at least 25 years we've been talking about the imminent crisis in the cost of health care, of social care. and it's been talked about for decades. And governments of all political parties, even the Lib Dems were involved at one time, of all political parties have said, oh yes, we'll do something about it, we'll tackle this, and no one has. This doesn't fully tackle it, by far from fully tackle it, but at least it's a start. And one of the reasons governments haven't been tackling it is because someone has to pay. And whilst recognising that the future costs are far greater than the currently expected future provision, no one has been willing to say, well, then the cost has to lie with A or B or C, because ultimately it'll have to. So regardless of our personal politics here, I think we should be grateful that at least we've now started to have this very difficult conversation about who is going to pay for the healthcare and particularly the social care costs that so many individuals are going to incur over the course of the next few decades. And in that context, I know that it is said in the report that this is meant to bring the health and social care systems together on a more sustainable footing. But my concern here, and it's a particular concern about the spread of the additional income over the course of the next 3 years, my concern here is that we're not bringing them together on an equal footing nor on a logical footing. Because within both the Health Committee and the Adults Committee over the course of the last few years, I think there's been a fair amount of unanimity that in the system as a whole, in the health and social care system as a whole, the social care side is undervalued. And it's undervalued, I'm not saying in terms of the outcomes for individuals, I'm talking in terms of the preventative costs for the system as a whole. And there continues to be a bias, and in my opinion, an incorrect bias, in favour of the health side of the health and social care system and against the social care side. And even within the health side, there's a bias, and I think a very dangerous bias, towards the acute sector, which has a great deal of PR with lots of pictures of hospitals and so on, against the primary care sector, which I believe should have a far greater proportion of resource enabled to it to allow for a greater preventative work to be done. And I constantly feel that when we don't talk about a health service, we talk about an illness service. And it goes back to the last item that we were talking about as well. There is far too much short-termism, especially on the acute hospital side, and we end up with a situation where we are failing to make sensible long-term decisions. And whilst the next 3 years isn't necessarily long-term, that's one of the reasons why I'm disappointed that the additional money which is being generated and which is being talked about here is so heavily biased, again, towards the health sector and particularly towards the acute sector. And I feel that it's an opportunity which is missed, and it's something which I would hope that this committee at an appropriate time, and I know we're going to have further discussions about this subject in principle, but I hope that this committee will come together to make recommendations and to lobby for a more appropriate balance within the health and social care system between social care and health, and within the health side, a more appropriate balance between primary care and the acute sector. So yes, I welcome the fact that the nettle is finally beginning to be grasped by a government. Let's hope it can be built on. But let's not also overlook the bigger picture here. And that bigger picture is that balance between the whole system, which I believe that the current health and care system is quite imbalanced. And I would hope that this committee will continue, as the previous Adults Committee and Health Committee had, to make that point and to stand united in trying to make sure that we have a more sensible balance in future. Thank you.
Thank you. I note and welcome the spirit of that contribution. So in the same spirit, I'll say I agreed with a lot of what was just said. So thank you. And I will just say that our officers are always fair and unbiased, without question. So let's just put that one on the record. Next, we have Councillor Wilson, please.
Thank you, Chair. And I agree with what Councillor Bowden has said, that it's great that a government has now grasped the nettle and is beginning to deal with this issue. I guess I should start by declaring an interest, because I'm assuming that I will be one of these working age pensioners who will have to start paying the health and social care levy in due course. Which I'd not really thought of before, but it seems perfectly appropriate that I should be contributing towards my and other people's healthcare and the enormous backlog in acute and other hospital health activities that there is. I've got a few questions. One, I'm really uncertain about what the government is proposing about accommodation costs versus care costs, because I think that there was absolutely nothing in the announcement about that. And I'd be interested to hear from Will what the rough percentage is between what people pay when they go into a care home. Secondly, if, again, raising something which I raised earlier, if somebody comes to my home to provide me with care, does this announcement affect anything there at all? And when are we going to hear more about what is being proposed? It's all very well grasping the nettle and starting off with something, but unless we actually begin to see the details and officers can then work out precisely what it's going to mean for the county council and individuals in the future, it's pretty meaningless. So rather than simply noting the report, Chair, I would like us to encourage officers to go back to government, the LGA, ADAS or whoever to seek more information urgently so that we can do proper business planning. Thank you.
I'll take that as notice of a possible amendment if that's the mind of the committee at the end. The next person is Councillor Howell, please.
Thank you very much indeed, Chairman. Let's not forget Tony Blair in '97 was going to reform the social care in the UK. So we've been waiting a little while, and I think I'm looking at Charlotte here, and I think he was going to build upon the 1990 Community Care Act, if I remember rightly. Anyway, with regards to this, and this is a very slim white paper that was actually published, my question is, it's nice to see at the opening paragraphs prevention is mentioned, which is excellent. We have already been seen from the last speaker with regards to assistive technology. I think there was a saving of 3.6 million with regards to preventative care. Are we going to be able to use our own figures, or do we think there will be a national standard with regards to prevention and how we can actually note what that is so we can report back to the government? Thank you, Chairman.
Thank you. And in order to preserve fairness and lack of bias, we won't be asking Charlotte to comment on Tony Blair. Next, we have Councillor Slatter.
Yes, knowing that this is actually a public meeting, I suppose I should speak up for some of the people who will be as outraged as I was at the suggestion that there's not been pressure going on for either prevention or primary care funding. Of course there has. There has been some progress. I agree, though, it doesn't always attract the same amount of public attention or fundraising as the more dramatic acute care. I appreciate that. But this is where the liaison groups come in very handy, and we have the privilege as councillors to join in on those. And I myself have been quite forthright with the NHS colleagues in terms of making sure there is enough, when we rebalance things with the CCG, that the primary care, which I must admit was always something I was interested in. I don't think that is actually a declaration of interest. But the primary care can be so important, not unlike primary schools, really. So that's one point. It is down to us, I think, to be honest on the doorsteps with the voters. I am, and I find they take it, they take it quite well if we say this has to be paid for. And I urge us all to do that. Unfortunately, people lack the fiscal vocabulary, shall we say, to make it in a gentle way as to how it is paid and what taxes are paid by whom, but it does have to be paid for. And I think we must all be honest with the voters in that regard. And you might be cheered if you actually tried it, Councillor Bowden, to find out how straightforward how people appreciate that sort of honesty. I certainly have. The people will take it on the chin, and there are a lot of elderly, wealthy people like myself who are quite prepared to pay. And so was my father, who sent his taxi card back when he found out how it was funded. But I think that's it wasn't a question. I apologise, Charlotte, but I have found your. Thank you very much for taking. Sorry, Charlotte, Will, for taking on writing this very difficult report to write.
Yes, of course, straight away.
Thank you for your comment, Councillor Slatter. I have a reputation within my division of being very forthright with people and giving my views, regardless of the party politics which may be involved at a national level. And
Okay,
I have
it's
repeatedly,
point made.
both
Point made.
locally
Point
and
made,
here,
Councillor
made
Bowden.
exactly the points
Point
that you were
made,
just saying.
if you just, yeah. Okay, I think that's been made, and we don't need to focus on that. I do have Councillor Dupree, please.
Thank you very much. I think while, yes, there has been talk over a long time about grasping this nettle, I think that, and while we need to recognise that this needs funding, I think there is deep concern about a number of things that have come out of this. I think the proposal that the care costs for people who need that care will be borne predominantly by young people of working age on low income through national insurance is extremely disappointing and extremely unfair. I think also that there are unknown risks. Well, we know what the risks are for the authority and for the public finances. A lot of this will be loaded onto us as a local authority, and we don't yet know exactly how that is going to fall. We will have to wait for government announcements on that, but I think the suggestions in here are that news will not be good. And I think there has also been a slightly over-optimistic presentation of this proposal by government to the public in suggesting that there will be a cap, and yes, there will be a cap, but only on part of the very substantial cost of care, as Councillor Wilson has mentioned, that the costs of accommodation are not included within that cap. And I think once people realise that fully and experience that fully, there will be a lot of disappointment about this as well. The other major issue, and again, I think it was Councillor Bowden who alluded to this, was the small proportion, just over a seventh of the money that was announced coming into social care over the next 3 years, when we recognise that social care, through demographic pressures and other pressures, is taking up an increasing proportion of local authorities' resources to meet the growing need there, and the backlog as well of that care, and the number of people who just need care and aren't receiving it from anybody despite asking. All of that leads to a situation in which this ultimately, I think, is very disappointing and very concerning. It's not really grasped the fundamental issues that need to be grasped. And I think that should concern us all. I'm assuming that we will receive updates on this during at the very least during the budget build and the business planning process, as this may well throw an exploded device into all of that. And I'd be grateful for some sense of how we're going to be updated as this develops, as it clearly will over the coming months.
A few comments from me. I take the point we don't want to repeat the national party political debate about this that's taking place in the House of Commons, and we should try to look at this from a Cambridgeshire and local perspective. But I have to say, if you take those words, grasp the nettle, it isn't, because it doesn't provide the long-term solution, which is what everyone needs. It's starting yet another debate, but it's not actually getting us anywhere near the solution, and I'm really troubled and worried about this. And the biggest thing that worries me is the point for our electorate, for our citizens, that you see in the age concern report that's referred to in this report, that 90% of the people who need care are not going to get it in any extra way because of this proposal. And surely those are the people that we're most here to bat for. I don't think in 3 years' time money is going to be taken away from the health service to put into social care. I don't see this as a one-off amount of money to enable the health service to catch up. Because I'm sure, though that's the sincerity of the government intention, I think in 3 years' time we'll see that the need in the health service will make it very, very difficult to take that money away through no fault of anybody. So I don't think that's the right way to have this funding mechanism. And as others have said, and I would want to endorse from the chair, You know, this has very specific responsibilities for us as a local authority. We're going to have extra need, and we're going to have the need to develop our capacity in order to be able to deliver that extra need. And both of those are going to put costs onto us. And it is in the white paper. It would have been helpful if it was a bit more upfront in the white paper and not hidden away. But it is there that the precept and so-called efficiency and the council taxpayer is going to have to bear the brunt. There's some really honest and bitter truths that we're going to have to live with in relation to that if nothing changes on this issue. And it is only responsible for us to say that now, to analyse it in further detail, and then, because of our responsibilities, to plan for it, however difficult and challenging that is. So I very much welcome the fact that, with everyone else, that the officers have begun to get us informed on this and that we're starting to have some collective thinking on this across the committee. I welcome the debate, by the way. I think it's been a very good debate from all sides and reflects well on this committee. And it's clearly something that we're going to have to come back to. I will take Councillor Wilson's point as an amendment, but if Will could sum up first, and then we'll come to the procedural bit. Will.
Yeah, thank you. So, as I said in the introduction, many more questions than answers, but I'll try and respond where I can, given what we know. So, in terms of the priority being the COVID backlog, the announcement is very clear about that. That's a bit of a double-edged sword in the sense that there's a huge amount of unmet need there that does need to be addressed. But as we've said, the announcement is silent on the local authority element of supporting meeting that unmet need. And that links in, I suppose, to the point about the spread of income over the 3 years and how the funding is going to be distributed and what conditions there'll be is still unclear. As far as accommodation costs versus care costs, it's very clear that in the announcement that it just covers care costs, which is a very big difference from today, where we fund both accommodation costs and care costs collectively. But it's very clear it is just care costs. And in answer to what's the percentage split between care and accommodation, I'm afraid it varies very significantly depending upon, you know, whether you're in a residential home or supported living or extra, you know, it depends on what care setting you're in. And it's further complicated by things like housing benefits and what have you. So that is an area that we need to understand the impact of in more detail. In terms of home care, it's the assumption that we're making at the moment is that will just cover care costs because the individual is at home. And then the last thing I would say is that our priority is to understand how the announcement and as details are released, how that impacts on our local residents, on our providers, on our workforce, particularly on our care workforce, our providers, and obviously ourselves as the local authority. And that's in terms of sort of asking for more information and more detail. I can assure the committee that we are actively doing that.
Thank you very much. I will take it as an amendment, though, which will strengthen that. So Councillor Wilson said that we should express our concern about the lack of clarity on local authority responsibilities in the announcement and call on the government and through the LGA and ADAS for more information to try and reach that clarity. Do I have a seconder for that amendment? Councillor van der Ven. Is anyone wishing to speak on that amendment further? Just looking at the Conservative side, is this controversial? Do you want to vote?
Thank you, Chair. As a local authority, we of course want more information and we want it as soon as is possible. It's not what the sort of detail you expect in a white paper of this nature at this stage. So we're asking, what's being suggested in this amendment is something that we all would want, but I think it's a bit unrealistic for us to expect it. So I've got no problem with us saying we want it, because we do want it, but let's not be unrealistic here.
I think the answer was yes, because it was a procedural point. So, first of all, on the amendment, does everyone agree the amendment? Again, I'm looking round. Yes, that's unanimous. Yes, to express concern about the lack of clarity on local government responsibilities in the announcement, and to agree to press the government and through the LGA and ADAS for greater clarity on the local implications for local government. Happy? Okay, so people did nod. I haven't forgotten that wrongly. They did nod, did they? Did I ask?
I've thought.
I'm going to do it again, sorry. Yeah, is the amendment agreed? Yes, I'm seeing nods around. Sorry, I just was so careful about getting the wording right that I might have done it twice. And the report recommendation is that we note and comment, as we have done, on the potential implications. Is that recommendation agreed? Yes, it is. Anyone against? No, that's agreed unanimously as well. We'll take one more item before the comfort break, and that's item 7. Welcome to Jyoti. And this is key indicators for health inequalities in Cambridgeshire. It's on page 61 to 74 of the agenda pack. And Jyoti, I think, is going to be accompanied by Emmeline Watkins in presenting that. Is that right? So if Emmeline could...
No,
it's just going to be Jyoti. Okay. And just to say to the opposition, if you recall, we had a long discussion last time about whether this report should come on this meeting or another one, and there was an amendment, and it was 7-6, not to say a specific meeting, but we've managed to get it here. And what I want to say to the opposition on that is, I appreciate we're all new and in new responsibilities, but have some trust here. If you ask for something, we'll do our very best to do it. But on some issues like timetabling of issues and whether officers really do have the time and capacity to produce a report in a particular deadline, trust us to do it without us having to be tied down on that. And this is a good example where we've managed to fulfil what the opposition wanted. Jyoti.
Thank you. The paper talks about summary inequalities measures as requested at the last meeting. It focuses mostly on socioeconomic inequalities rather than other forms of inequalities that are described through their protected characteristics, for example. And whilst it outlines a summary measure, it's really important that we continue to dig and understand in more depth the inequalities that our population face through the JSNA and COVID impact assessments, and that we then address those inequalities through the health and wellbeing strategy as it evolves. The paper clearly demonstrates that there's a north-south gradient in inequalities across Cambridgeshire, but it also demonstrates that when you drill down into more localised areas, inequalities do exist across the patch. There's no perfect measure. All measures have their limitations, and those are addressed in the paper. And there's a number of particular measures that are explored in terms of advantages and disadvantages for their suitability as a summary inequalities measure, and they are life expectancy. And it's a strong measure. It's well understood. The calculations are well understood. The limitation of that as a potential measure is that life expectancy could increase, but quality of life may not. And I think that's a really important consideration. The quality, the number of years spent in good quality is at least equally important, or perhaps more important than the number of years lived in totality. There's also consideration given to gap-based or gradient-based measures of inequality. And one of the limitations, or the major limitation of those types of approaches is that you can have areas that are clearly experiencing deprivation, but have a shallow gradient. Does that make sense? Yes, it's quite a complex concept. Good. Then there's consideration about healthy life expectancy as a measure, and whilst that might be a desirable measure to look at, the way in which it's calculated is very complex and has changed over time, so it would be difficult to track progress against healthy life expectancy, and difficult to use that as a measure of understanding sub-local authority level inequalities. The one that's advocated as probably the best measure to use for inequalities is premature mortality that's considered preventable. So causes of mortality under 75 that are considered preventable. And there's a graph towards the end of the paper that really does demonstrate quite a strong gradient between deprivation and premature mortality. So I'm happy to take questions and consider comments on that. So the recommendation is that we use premature mortality as the summary measure, but support that with more detailed analysis of inequalities through the JSNA and COVID impact assessment.
Thank you very much indeed. And just to say to all the committee, this is very much a report about methodology and about indicators. It's not a general debate about health inequalities. So let's try and focus our discussion on that. I have Councillor Bowden.
Thank you, Chairman, and thanks to the Director of Public Health for getting this report at this meeting. And the reason that it was requested and we pushed it to the vote was because of the priority that we wished to give it. And I'm pleased to see that sufficient priority has been given to this for it to come to this meeting, and gratitude to you as well for the part you've played in making sure that this has happened. I've had some interesting discussions with the Director of Public Health, and no doubt we'll have many more in the future, as I did with the previous Director of Public Health, and for that matter the previous Health Committee, about health inequalities and the measurement of health inequalities. And those who were on the previous Health Committee will know that this is, I'm not starting this afresh. This is something which I've been talking about for some considerable time. It is my impression, and I'm sorry to say it's my impression because I don't actually have the data to prove it. I suppose I could do all the work necessary, but the data hasn't ever been presented to this committee nor the previous Health Committee. But it's my impression that Cambridgeshire has the greatest amount of health inequalities of any of the Shire counties in this country, or in England at least. Now, I may be wrong about that, but that's the impression that I've got. So we have, in my opinion, a real issue so far as health inequalities is concerned, and it's a bigger issue than other Shire authorities have. Now, we pay lip service, at the very least, to the fact that we believe health inequalities are wrong and they need to be addressed. And what I believe is really important is that we have robust measures of robust methods of measuring health inequalities and measuring the effects of our impact on health inequalities, that we can see what direction of travel we're going in and what, if any, additional work may be needed. Now, we are ultimately most concerned about the underlying health of, and public health we're talking about here in particular, but the underlying health of individuals and the absolute health rather than talking about comparative health. We want to increase the absolute health of individuals. And ultimately, the easier way of doing this in many respects is to improve those whose position is at the worst, the bottom of the ladder at the moment. And we find ourselves with a situation where there are stark divisions within Cambridgeshire. And yes, it does depend what geography you use to measure this. If you base it on the geography of our district councils and the city council, then it produces a very, very stark north-south divide. Once you go down to medium super output areas, or even where the data is available, lower super output areas, then there's a lot more granularity which is involved in that, and you see that there is more distinction in certain areas. Cambridge City is a prime example where there is quite a wide disparity within the city itself, but still overall, the overall imbalance between north and south within the county is absolutely stark. And I would hope that we could move, because here we're just talking about ways of measuring health inequalities, I would hope we could move to a system which would allow a reporting to take place to this committee that we could measure. Now, all of these measures, all of this reporting that takes place to do with outcomes on health, they've all got time lags. And we're always looking backwards in time, and it's quite frustrating very often when we are interested in what's happening now and what we're going to do in the future. But that is just the way in which the system works. And I welcome the suggestion by the Director of Public Health that what we need to concentrate upon is healthy life expectancy rather than life expectancy. Now, I believe that's a rather an important distinction, and it's one which will be worthwhile having a discussion about within this committee at a certain point. The distinction between the two is significant, and it actually has implications when it comes down to decisions that we make. Are we meant in this committee to be making decisions to increase life expectancy, or are we going to make decisions to increase healthy life expectancy? And sorry, that might sound like playing with words, but it's not. It's a matter of what will we be targeting. And I believe the Director of Public Health is correct in targeting healthy life expectancy rather than life expectancy, but that does have implications that we need to talk about. And I also believe that the Director of Public Health is quite correct in saying that one measure which is very clear and it's able to be calculated reasonably quickly by the standards of health information, and also reasonably consistently in terms of what happens across the country, is preventable premature mortality. So I believe that's an extremely useful indicator to be used and to be reported to us. And the one thing which we don't want is a plethora of data coming to us, very often in different forms and with different timelines, which we just be buried under. But rather than just having that one indicator to concentrate on, I'd suggest a second one, which also has quite a robust methodology and is also not unreasonably delayed in its reporting, and that is the data on diabetes. And I just wonder whether as a second indicator, diabetes could be included as well as preventable premature mortality. I don't want to go into lots and lots of different indicators, that would just confuse the issue. But I just wonder whether that second item of diabetes would be a very useful one also, because the diabetes figures that we have within this county are starkly different compared with in different parts of the county. I welcome what's in the report. I hope we'll move towards actually starting this process rather than talking about how we will do it. And I know that the Director of Public Health shares this as a priority of what it is that we should be doing, and I hope that all of the committee share it as a priority. And I've got a suggestion I'd like to make to you, Chair. And I'm not going to push this to a vote for myself, because I'd like you to adopt this rather than trying to make it a divisive issue. But we have in all of our reports, at the end of each report, we have significant implications. And in those significant implications, we have 8 criteria which are measured, and there are 8 sign-offs which are made at the end of every single report, including this report, if you go to the end of the report. And I just wonder if, for this committee, for the Adults and Health Committee, if we could add another criteria. And that extra criteria is an assessment of how, or if, the report addresses health inequalities in the county. Now, I'm not saying this is a panacea, but it does help, it will continue to help to focus our minds on this most serious issue of health inequalities. And as I say, I'm not going to press this to a vote now, but I'd like to put it to you that it may be an appropriate thing for to change, and it may not even need to go before this committee at all. But it just seems to me, if we are serious about prioritising reducing health inequalities, this is one way in which we can do it, even before we start seeing data coming to us on a regular basis. Thank you very much, Chairman.
Thank you very much. I will come on that when I do my closing points. I won't do it straight away. Councillor Van de Ven.
Thank you. I'd like to make a slightly tangential comment, and I hope you won't think it's either cheap or taking too many liberties. But here we are sitting at a location as councillors that not everybody can get to. And it's a symbolic point. We're talking about socioeconomic factors and inequalities. We're talking about geography in this county. We're talking about access and quality of life, all of those things, and we're talking about action. And we as councillors have responsibilities for decisions, and we have chosen a place to be, and I'm just so cognizant of it this morning, that I'm able to be a councillor because I can afford a car to get here. And that has to do with where I sit on the spectrum of inequality. And I'm furious about it, and I feel compelled to say something. I wasn't planning to bring it up under this item, but forgive me for doing so, but I felt compelled. Thanks.
I do forgive you, but could I just ask other members not to comment on that, because then we're going to have a whole debate about something which is other than what's in the report. But those comments will do stand, and I'm not disagreeing with them, but that's not the main focus of this morning's debate. Councillor Dupre.
Thank you. I thought this was a very interesting report, and it's the kind of thing that does particularly interest me is the data we know, but also the data we don't, I think. And some of what surfaced for me in this report is that there are things that we don't know, data we don't have access to, that could actually make a significant difference to the decisions we make. And if we are prioritising improving healthy life expectancy, and I hope we do, and I agree with Councillor Bowden that that's a very important thing, that not just the length of someone's life, but the length of life that they live in a good state of health, or at least a satisfactory state of health, to enable them to enjoy a quality of life. Then there are things that we don't know. We're told here that it's not a good measure for understanding inequalities, as it's not available at smaller geographies. And I think the more granular the data that we have, the more useful it will be in enabling us to focus our attention on the things that really matter, and the inequalities which aren't as simplistic as a north-south divide within the county, but where there are real significant areas of inequality and deprivation in the south of the county, as well as some areas of comparative affluence in the north of the county. And we need to understand that better so that we know where to pitch our interest and our efforts. And therefore I wondered whether we could follow on from this report by firstly at some point having a workshop to talk about some of that in more detail, the very data stuff that we've got in this report and what we can do about that, and also whether there was a drive within this authority to seek to work alone or with others to fill in some of the gaps in the data that we don't have. We've got a very good data team here, I have to say, under Tom Barden. I've been incredibly impressed by the work that they've done, and also the Public Health Intelligence team and everybody that's pulled together to bring lots of data to the table. But there's stuff that we don't have, or don't have in sufficiently granular detail down to LSOA level rather than MSOA. And I wondered whether firstly there were grants that could be accessed to do that, pieces of work that could be bid for, partners to work with to try and improve the granularity of the data and to get the missing data that will enable us to focus our efforts better. And I would really like to see a piece of work that did that, because I think it in the long term would pay back by enabling us to be much more sharply focused in our efforts and interventions. Thank you.
Thank you. And if we take your previous point about a workshop, if we take it as read, then that's another thing to put on the list for the trading plan alongside the other areas when we note that later in the meeting. Councillor Slatter is the last speaker.
Thank you, Mr. Chairman. Yes, I would thoroughly agree with Councillor Bowden about including diabetes. I presume you mean type B. Yeah. And in my mind, as I'm sure of us, I'm glad we've also got our healthy weight campaign and so on. But we also know how difficult it is for people to get to grips with that problem. If they have a weight problem, to actually get to grips with it. Case studies will come up to all of our minds, probably within our own families. And I'm a tremendous admiration for my daughter's father-in-law who did get to grips with a weight problem and now finds he doesn't need the knee operation that otherwise he wouldn't have been allowed until he'd lost weight. Now that is a classic, and it's the same conversation I had with a friend yesterday. She has her husband will not go to the doctor about his knees because he knows he'll be told to lose weight, and he doesn't want to have that conversation. Now we all, whatever, there's a gradient, yes, but we all have many residents in our wards, wherever we represent, who are in that situation, and whatever we can do is very hard to deal with. So I would really recommend those sort of case studies that perhaps show us ways in which we can help people to take that step. I saw quite recently on the television, there's just the manipulation of the image of somebody, so they could look in a mirror, wasn't a real mirror, and see themselves slim, and had that image that would possibly come between them and the chocolate muffin, and if that really worked for people, and if we're looking at prevention of further health problems and joint issues and such like, anything like that, we're good gadgety people in Cambridgeshire. Let's pick up on any of those, and hopefully if we as councillors come across success stories, and that's the granular level, and I can think in my ward there's a tremendous disparity of health and indeed of wealth. But we also know there are people who are wealthy who just cannot quite get to grips with the problems that they have as individuals. So let's share good practice, please. And I'm sure that's not a question, are we going to share good practice? Of course we will, Jyoti. But if you can give us help with that and personalise the stories, the people who actually have transformed their lives, who may be able to help us with that too, because they're the experts if they've taken those steps themselves. Thank you.
So Miss Councillor Gay, who'd indicated. Councillor Gay, please.
Yes, just very briefly to the Director of Public Health. It looks to me as if the life expectancy and avoidable mortality criteria are very highly correlated. So I just wonder if you could comment on the extent to which that distinction is valuable. And second,
can I just check? There's some distortion on your microphone. Did you get that? Would you mind just moving to the next microphone? Or it could be moving the laptop away. And do you mind just summarising your first point again, Councillor Gay, because I don't think everyone got it.
Yeah, is that better? Yeah, so my first...
No, there's still a problem. Could you use a different microphone? See if it's that microphone.
Okay, is that one better?
It is indeed.
Excellent.
Thanks.
So my first point is to the Director of Public Health. It looks to me as if the life expectancy criteria and the preventable over 75 mortality are very highly correlated. So I just wonder if you could comment on the added value that you get from looking at the latter criteria. And the second point, very briefly, is I don't think that diabetes is a particularly good measure to use in this case, because although it is describes a condition where there is dysregulation of blood glucose, it's actually clinically highly heterogeneous. So I would disagree with that point.
Thank you. A few comments from myself. One is I really thought that the figures in the report about inequalities within districts were really important, and this point that inequalities exist everywhere. Yes, there's a north-south divide in Cambridgeshire that we must be cognizant of, but in Cambridge City itself there's a 10 years difference in life expectancy depending on where you live, and I think the report really makes the case that we have to help people who are suffering from health disadvantage wherever they live in Cambridgeshire. I thought that was a really important conclusion from the report that I got. I do agree with those in the debate who said importance as statistics are, and I think our public health team, to give them feedback, are brilliant at the analysis. What we have to do as a committee is to work out, and I agree that this initiative is motivated by this, but to work out which indicators are actually useful in informing what we do to change things. And that is our priority. Our priority isn't analysing it to the nth degree. Our priority is changing things for the better. And I hope that's the outcome that comes from this report. In terms of the recommendations, I've listened carefully to what people have said, but they cover health, good health, living in good health, life expectancy in good health in little I, and then as a lead indicator, preventative mortality. And I think that's what Jyoti said in your introduction. So we'll hear what Jyoti says about diabetes. I don't want to prejudge what she's going to say about that. But that's what we're invited to agree, along with the Joint Strategic Needs Assessment. So, and I don't think I've heard anything in debate other than the question about diabetes that would question that. Those recommendations. Finally, Councillor Bowden, I hope you'll be happy if we minute the suggestion and my response that it should be considered. But I tell you frankly my personal view, I think those bits at the end of all these reports in all the committees are not working. I think you end up with, whether it's environment, whether it's health, you end up with, one ends up with boilerplate answers too much of the time, because our officers haven't got the time and capacity to really, in all the different specialisms, to really address in detail reports that they're not directly responsible for. And so I'm worried that it's not effective, I have to say. So just adding another question on at the end, unless we really feel it would be effective, I would have some concerns about. But I'm quite happy that we note the suggestion, because I think that's an issue for the authority as a whole, not just for this committee. And if we were to be able to change that, then I might have a different view. And it does come back to our commitment in this committee to a health in all policies approach, and how we implement that. And we're absolutely sincere in that. I think we've declared our commitment, but delivering it is what we're in the business of doing, and we're clearly not yet there. They're step by step, and when we come to business development next month, I think that's an area that we should address. So that's my response to that point. To be fair to Councillor Bowden, I'm going to allow you to come back just on that point, and then I'm going to ask Jyoti to respond.
Thank you. I'm perfectly happy with that response, and you noting it and giving it consideration. And I also share your opinion that the 16 points we have at the end of each report aren't necessarily that productive and helpful. In this case, however, I think it would be a different matter, at least as far as the Adults and Health Committee is concerned, because the Director of Public Health is aware of the priority that needs to be given to this, and I think that she very clearly understands how each report that we have, which is health-related, how it does interrelate with inequality. So I think in this one case, we'd actually be able to get something from someone who would be able to do it with relatively little additional work, but giving us useful information.
Okay, and but not to prolong the debate, so this is a last comment. I hope the fact that we've got an integrated approach and that public health and social care, adult social care working together means that that input is there, but it's in the main body of the report. It's not an add-on afterwards, and that is the intention that we have in integrating the work in this committee. Jyoti.
Gosh, there's enough there for me to be talking about for days, so I'll try to be concise. I think that anything that we've tried to do that's targeted at inequalities, interventions that have been very targeted, don't deliver the desired outcome. What we need is universal approaches that are systematic and then proportionate responses according to need. And if I could give you some examples to illustrate that. If we didn't visit every child through the health visiting service, how would we know which children needed more help? How would we know who to target? So we absolutely need that universal approach to identify those who are in need. There's another question about how we would target if we didn't have a universal or systematic approach to identification. And if we just used a kind of ward-based approach, we would probably miss out on the majority of individuals who could benefit and who were experiencing inequalities. So I would very much advocate universal, systematic approaches that are proportionate to need. Of course, then there needs to be a bit of a horses for courses consideration. So, for example, smoking now as it's reduced, as prevalence is reduced, has become almost entirely an inequalities issue and needs targeted responses. However, obesity affects about 70% of our adult population, and a targeted approach is not going to conquer that issue. In terms of whether we should pick diabetes, I think there are 3 main clinical risk factors, and I wouldn't pick necessarily one above the others, and they are diabetes, blood sugar, hypertension, and cholesterol. Hypertension affects more of our adult population. Sorry, frog in my throat. Adult population. So it would be, I don't think I could justify just picking diabetes. I think we'd have to have a systematic look at all of the clinical risk factors. And hypertension may be one that drives inequalities more. The data point, I think, was an excellent point. We've actually had a bit of a drop in the data that's been available to us because of the pandemic. So things like our National Child Measurement Programme haven't happened because schools haven't been in and we haven't been able to measure the weight of children. A lot of the surveys haven't happened during the pandemic for obvious reasons. So there is a bit of a dearth of more recent data, and we're relying a lot on pre-pandemic data or COVID-specific data to inform our actions. And I think it'd be really worthwhile exploring how we could invest more in understanding our population, and we do have some reserves that we could possibly put to that. So that's something I'm actively considering at the moment. And obviously working with academic institutions to support our understanding, that would be a great thing to do. Absolutely agree with the use of case stories, personal stories. I've used those before in previous jobs, and they're brilliant at actually recruiting more people into our services as well, and getting more attention through the media for our services. So yes, that's something I'd like to develop further. Have I addressed everything? I'm not sure. I could, as I said, I could talk for days. I think it would also be good to look at that issue of healthy life expectancy and exploring that a bit more versus life expectancy. You're absolutely right. It could change the emphasis of what we do. For example, if we were more interested in life expectancy, we might want to focus on infant mortality. There are very few infants that die. If the emphasis on health is on healthy life expectancy, we might be more interested in low birth weight. There are many more children that are born at a low birth weight, and it gives us more information on which to act and particularly target inequalities, for example. And that's something I think would be worthy of further exploration at a meeting like this or at a workshop. Thank you.
Thank you. These are the recommendations. To note that we've considered ways of measuring health inequalities in Cambridgeshire and the timeliness of the measures available, and agreeing an ambition to improve the time that people live in good health in Cambridgeshire and to reduce inequalities in health outcomes, to monitor under 75 mortality from causes considered preventable as a lead indicator for inequalities, acknowledging the lag in the timeliness of data, and to continue to use the more detailed and timely data in the Joint Strategic Needs Assessment and COVID impact assessments to inform our health and wellbeing strategy and key areas of focus for action. I don't think there'll be controversy about that. Is the committee happy to agree that? Again, I'm seeing noughts all the way around. Anyone against? No, that is agreed unanimously. Now, colleagues, we've made pretty good time. We've dealt, the way the agenda is structured, we've had the most discursive items already, so there's some important business items to come, but ones where I think we can move more quickly. I do think we've got time for a comfort break, so I'm going to announce 5 minutes and try and be back by 12:10, please. Could you take your seats again, please? One of our fellow chairs in the joint administration has just set me a high bar test. Right, but in all seriousness, we've dealt with the most discursive points. These are the business points. Any questions that want to be answered absolutely will be asked. There's no problem about that. But I envisage that we're able to move more rapidly in the remainder of the agenda. The first item is item 8, expansion of the in-house lifeline service. It's on pages 755 to 86 of the agenda pack, and this is one key aspect of the tech that we've discussed already today. So I think we've had the debate about the importance of tech and lifeline within it. So let's just focus on the exact recommendation in the report. And Sarah Bai is with us. Thank you very much for joining us, Sarah.
Thank you very much, Chair. I'm pleased to be here today in front of committee. The report seeks approval to invest in the Council's tech team lifeline service in order for the service to be offered to other partners and to grow the tech offer. The annual investment of fixed costs and variable costs is expected to be fully recoverable as part of the proposed financial model. It is the intention of the tech team to reinvest any surplus into trialling new technologies and to continue to develop a proactive approach to preventative support for individuals. The committees were recommended to approve the expansion of the County Council's Lifeline service, enabling the Council to provide service to other authorities and partner organisations. Note that the expansion of the service will enable more people to be supported to live in the home of their choice, and also to comment on the approach of expanding the service to reinvest in local tech provision with any surplus used to test emerging digital technologies that will benefit people across Cambridgeshire. Thank you.
Thank you very much. Any questions or comments from members? Councillor Hay, please. Sorry, not Councillor Hay. I'm looking down. Councillor Costello, and I do apologise. I am learning names. I want to underline that, apologise and welcome your contribution. Councillor Costello.
Thank you. I'm a great believer in the lifelines. My mother has one, and it gives such security to family members and obviously my elderly mum. The thing is that I'm a bit concerned about how much the county council is charging. My mum's lifeline is supplied by a private provider and annually costs £168. Yet, from what I read here, the total cost for somebody on our lifeline will be £260, which is a considerable difference. Because it's still providing the same service. I do note that some people won't have to pay this because it's offset, but that's £100 difference. And are we being commercially, considering other commercial providers and providing a cost-effective service? Thank you.
Thank you very much for that. Again, if you could note all the questions and answer at the end, please. Any others, questions or comments? No, I think it's a very fair question. By the way, I'll be looking forward to hearing the answer. But overall, we were earlier. Oh, Councillor Ray first.
Can I just sort of expand on that and ask the question? I noted in the previous report on tech provision that there was quite a big additional income from it. And given the expertise that we're building up, how much potential is there for income generation? And are we exploiting that fully?
Thanks. Okay, so I'm going to very much look forward to the answers to the questions from Councillor Ray and Costello. Overall, just to underline, I'm not sure if you were with us before the break, but there was a lot of enthusiasm in this committee about a tech service. I'm sure we're going to support these recommendations, and very, I hope you can pass back to your colleagues how much we welcome what they're doing and are excited and interested in it, and we want to go and see the flat and so on. So yes, I hope that although I think there's a very proper question that's been put there that we should answer. Overall, I'd want on behalf of the committee to express the strong support we have for the activity in this area. Sarah.
Lovely. Thank you very much for those words of support as well. It's really appreciated. And I will pass that on to my colleagues. In terms of the £5 a week cost charge, so the tech team does build in a 6-week free trial period for people so that there is that option to have a cost-free trial of the service. In addition, we did some benchmarking with with the national organisation that oversees the telecare sector, and the benchmarking was very much that £5 a week was in line with a lot of other provision. I would also say there's a range of options as well that come with the Lifeline service. So in terms of the 24/7 response, the emergency response service, connected to the call centre, so you've got that peace of mind. So it's just all of those extra things that are commercially built into the costings as well to make sure that it's viable, but that £5 has been verified as a kind of fair cost to people.
Okay, thank you. Thank you very much. I think it's been heard, though, by officers, and there is concern on both sides in this committee around that. But I think we'll leave it at that. But it's obviously been heard. What we're recommended to do is to approve the expansion of the County Council's Lifeline service, thereby enabling the Council to provide services to other authorities and or partner organisations. To note that the expansion of the service will enable more people to be supported to live in the home of their choice through the provision of assistive technology, and to comment, as we have done, on the approach of expanding the service to reinvest in local technology-enabled care provision, with any surplus used to test emerging digital technologies that will benefit people across Cambridgeshire. Any controversy about this? Can I ask whether these recommendations are agreed? Again, I'm seeing nods all around. Anyone against? That's agreed unanimously, Sarah. Thank you. But stay with us, please, because the next item is also with you, as I recall, which is the item 9, the Integrated Community Equipment Service Pooled Budget. That's on pages 87 to 96 of the agenda packed. And Sarah, again, is going to I've now remembered where we know each other from. Right, Sarah is going to present the report.
Thank you very much. So the Integrated Community Equipment Service is responsible for the purchase, delivery, installation, collection, recycling and maintenance of a large range of health and social care equipment. The budget for the equipment service is a pooled arrangement between Cambridgeshire County Council and the Cambridgeshire and Peterborough CCG and is governed by a Section 75 agreement. In preparation for the new contract starting in April 2022, a review of the arrangements and contribution has been undertaken, resulting in a change of the percentage contribution to the pooled arrangement and reducing the council's contribution from 51.4% to 48.2%. The joint arrangement is managed very robustly and works really well for both the local authority and the CCG. The committee is recommended to approve that we enter into a renewed Section 75 agreement and pooled budget with the CCG, and also to note the risk share contribution of the partners as outlined in the report. Thank you.
Thank you very much. Questions and comments from members, please. Councillor Bowden, please.
Thank you, Chairman. I welcome the report and will not be opposing the report. However, I started reading this report and was pleased, and it's consistent with some of the comments I've made earlier today, I was pleased to see that a re-evaluation had taken place and that the majority of the cost share would be going to the CCG rather than to the County Council, and I felt that that was appropriate. When I got to the detail, of course, I saw that the difference was absolutely marginal, and we've gone, if you'll pardon my rounding the numbers, from a 51-49 split to a 48-52 split, which is not much of a change at all. We heard earlier at a previous agenda item that the ability to measure the beneficial effects for the health service of some of the changes that we put forward, some of the initiatives we put forward, is not particularly robust and is a bit difficult. And I wonder if, and I'm not suggesting that we change what's being proposed here today, but I wonder if a more rigorous approach may be helpful so far as the identification of health benefits from initiatives such as this is concerned, so that we can potentially have a more realistic split in future when we are talking about the benefits to the health service rather than the benefits as far as we ourselves in the council are concerned.
Thank you very much. There may be an interruption to the live stream, and if there is, I apologise. I think we're probably back now. If there has been an interruption to those people watching us, I apologise. Also, I didn't know Tamar could run as fast as that, and clearly you should have been in the Olympics for the speed that you just showed. Well done. Next is Councillor.
There's no interruption to the live stream, it's just the...
It was an interruption in the room and not to the live stream, so that's even better. But it doesn't stop the joke. Councillor Van de Ven.
Thanks. Just a small question, really, about the recycling rate. And is that considered good, or does it need to be better? Thanks.
I think we'd always like it to be better.
Hang on. We'll do you at the end. Keep it. I'm good for enthusiasm, but we're also seeing if any other members want to ask questions or make comments. There are a couple from me. Although it might look marginal, I really think that there's a case example here in the fact we have got more money out of the CCG on this and the way that we've done it, and I think the principle of that, as well as the amount and the learning from how that's been possible, is really important for this authority. So I congratulate everyone involved, including our CCG friends. You know, it's not a fight, is it? We've all got common aims, but we're all struggling with difficult finances. So I congratulate everyone who is involved in that. And could you just comment on the KPI of 5 days? So there's a lot in the report about what a jolly good thing that is and how it's met. But of course, if you're coming out of hospital, 5 days is a hell of a long time. Or if you've had a full, 5 days is a hell of a long time. And I'm sure you've got other KPIs and other approaches that take that into account. But it did spring up at me as I read the report. So I will just ask you whether that's the right KPI or what else is there as a KPI to make sure that the timeliness from the service user's point of view is there. Sarah. Sorry, I've got one more from Councillor Slatter, just drawn to my attention. Councillor Slatter.
Okay, it might have been answered by the question from Councillor van der Ven, but we'll see. This recycling thing, it's very much in the face of the residents. If they see something's not been collected or they can't give it back, that goes down really badly. It goes down badly with a lot of people, including the nurses, who sometimes find there's a whole lot of stuff there and you know somebody else who wants it. I've been known to have my knuckles wrapped for actually helping myself and taking it down the road. Yeah, but I know there are all sorts of rules about cleaning it afterwards, and sometimes it's not possible, and it takes a lot of storage, we know this. But let's be quite sure that everything is clearly labelled and it is easy for people to get it back. When my mother died, and that of course often when that's the issue, it was easy for us. We felt duty-bound anyway to pay the live-in carer a little bit longer so she doesn't out on the street. And she was able to be in there and there when they wanted to collect bits of information, bits of equipment, but she didn't know quite where it had all come from over the years. So clear labelling, obviously the bureaucracy is important there. And indeed, as much of that can be reused and passed on, the better. I mean, that's the advantage of the Zimmer frame as opposed to some of the more whiz-bang assistive technology, I think, is that you can keep using a Zimmer frame time after time. But so I think we're all on the same side there. But yeah, perhaps I'd like to know how you do it, because it is important, especially for the PR as well as the money.
I still want digital Zimmer frames. Sarah.
Thank you, Councillor. So in terms of the equipment types, we had, as you say, quite a robust methodology in terms of reviewing all the different types of equipment, and it may be easier to see in some cases the social care benefit versus health. So there are things like perching stools or Zimmer frames which help in terms of a social care daily living experience, and there are things like bariatric beds, which would be more very much a health a piece of equipment, and it's greater volumes around social care but greater value of pieces of equipment around health. So it is one of those things that we carried out a very, very thorough review of all of the types of equipment that are listed under the contract. So we have done that piece of work, but definitely it's something that we want to keep reviewing, and which is why we've done this as we have done so far. In terms of recycling rates, they are good. But they could always be better. We do push the provider quite hard in terms of recycling. We make that they have to report their rates to us, that they proactively contact people in terms of recycling, and particularly for those pieces of equipment which are high usage. So we know that they're going to be coming in and going back out of the stores very quickly. So it's of a benefit to both the provider and the commissioners for that recycling rate to remain high. We have got a process around that in terms of them coming back into the depot. They have to be cleaned, they have to be reviewed to make sure that they're still fit to be able to go back on the shelf, to be able to go back out again in terms of recycling. So there is a bit of a process around that, and that has to be managed in terms of the people to be able to get the equipment in, to be able, the technicians to be able to make sure that it's okay. So there's a bit of a process which sometimes enables or stops us just having loads of equipment back at the same time, particularly some of the bigger items. But the provider also manages their depot in a way that enables us to recycle, clean, get that back on the shelf as quickly as possible. And in terms of the KPIs around 5 days, that is one of the KPIs. So that's a standard delivery time, but we do have next day and same day services to facilitate those more pressing situations. So where there's an emergency and somebody required to come out of hospital, or they need a piece of equipment quickly, then the prescriber who's prescribing that piece of equipment can state a more urgent timescale around getting that in. But that was just one of the KPIs that we included in the report, but there are more, and the delivery options are there for people in a more urgent situation.
Thank you very much. The recommendations are to approve that the County Council enters into a renewed Section 75 agreement and pooled budget with the Cambridgeshire and Peterborough Clinical Commissioning Group, and to note the risk share contributions of partners as part of the pooled budget arrangement. Again, there's been no controversy in the debate. Are people happy to agree that? Yeah, I'm seeing nods all round. Anybody against? That is agreed unanimously. Sarah, thank you very much indeed.
Thank you. Thanks.
We now move to item 10, Finance Monitoring Report, July 2021 to 22. It's on pages 97 to 138 of the agenda pack. Justine Hartley, who's our Strategic Finance Manager, only joined us in that role a very few weeks ago and has been absolutely brilliant so far. So Justine, it's really good to see you, and thank you for everything that you're doing for us. As members recall, at the last meeting we didn't really get time to do justice to the finance monitoring report, so we've put it higher today, and it is an important part of what we have to do as a committee. Justine.
Thank you. Okay, so I wasn't going to go through it in detail. You've got a lot of information here in this report, and very happy to answer questions. Just to put it into context, and I'm sure you all know this, but just to remind you, what you've got as an appendix to the report is the full finance monitoring report for people and communities and public health. So you've got children's in there as well as adults. It's one big report because of the structure of the organisation, but obviously the bits within the remit of this committee are the adults bit and the public health bit. In this report, you've got lots of key activity data, bits about savings monitoring as well as the sort of overall position in terms of service by service, whether we're underspending or overspending. So I was just going to quickly reflect on where we are overall for adults, including the commissioning block. We are forecasting at this stage an underspend of just over £1 million for the year. We're still seeing pressures on learning development and mental health particularly. We've been seeing those for several years and we continue to see those now, driven by service users with particularly complex needs around learning disability in particular, and some of the transitions from young adults are expensive packages. In this financial year, that is being offset by an underspend in older people, and that is a sad consequence of COVID and the fact that we have had a reduction in the numbers of service users that we've been supporting compared to where we would normally be, because people have died before we would expect them to. So we are doing a piece of work at the moment, and we'll pick this back up again in the business planning paper when we talk about that in a little while, to look at what that means for our budgets going forwards. It's a very difficult area to forecast around because we really don't know what the impact will be post-COVID as we come out of the pandemic, what the impact will be on the service user numbers that we support. So we're doing an exercise on that at the moment to look at what has the sort of one-off impact been and what does that mean for our budgets going forwards. But for this financial year, overall, that is giving us an underspend against the amount that we had budgeted of just over £1 million, as I say, on adults. Public health, again, is just over £1 million underspend forecast. A lot of that, again, is about the pandemic, and particularly some of our GP services, the demand-led services. The GPs have obviously been focusing very hard on vaccinations and COVID response, and so the level of work that they would normally do hasn't been there. And also we've got an underspend in staffing because it's been very difficult to get public health professionals in because obviously there's significant demand for them across the country. So a lot of catch up there in terms of the post-COVID world. What will happen with the public health underspend at the end of the year is slightly different to what will happen to the underspend on adults. So the adults underspend will go into the county council's overall underspend. Any public health underspend gets transferred automatically to the public health earmarked reserve for use in public health spend in the future. So that was all I was going to say, but happy to take any questions on the adults and health section of the report.
Thank you very much. Councillor van der Ven, please.
Thank you. Thank you very much for the report. I just wanted to say I'm glad that you have highlighted the staffing issues, which we need to be really mindful of. And I believe the public health staffing issue includes the health protection role. And it just seems really important to take note of that. And I know that officers are working really hard in all areas of staff recruitment, and just what a vital time this is. So that was just my one comment. Thanks.
Thank you. Just before I call Councillor Bowden, I meant to say this at the start of the debate. This whole issue about the sad loss of so many people because of COVID, and then what that does to our services, there is a danger that we use inappropriate language that is insensitive to the bereaved and the families of the bereaved. And so we've actually had quite a discussion internally about how we talk about this, because it does impact on lots of things that we do. We will talk about it, and we've come on the words COVID loss. So if people want to refer to that, I'm sure everyone in the committee would want to be respectful of those who've died and their families and friends. But I think the words COVID loss are the ones that we recommend are used to be very, very respectful and sensitive. So I just put that out at the start of the debate. The next speaker is Councillor Bowden.
Thank you, Chairman. Two things. The first, on the adults side of the report, and I welcome the honesty within the report about the uncertainty as to the volume in the near future for demand-led services, and that uncertainty will, I'm sure, progress not merely in the current financial year but also into the next financial year and into the budget setting process. And I think it's important that we do recognise the degree of that uncertainty, and that we must be careful not to underestimate what may occur when it comes to these demand-led services. So keeping a very close eye on that, I think, is extremely important. But that's very honestly been stated in the report, and I think that's really helpful to us all. On the public health side, it's a different matter, as was explained. Public health underspends go into the public health reserve, and for members of the public who may not be aware of it, but I'm sure all members of the committee are aware, that has no effect on the finances of the council as a whole, since the public health spend is ring-fenced, and all the money which is budgeted for public health will be spent on public health, just not necessarily in the year in which it is originally budgeted. Again, for those members who were on the Health Committee previously, 2 to 3 years ago, we saw that the amount of the public health reserve was increasing gradually, and we made a decision then that it was appropriate to consider, and we did so on a very cross-party basis, I have to say, to consider how it would be appropriate to spend that money on transformative measures which could manage to improve public health. We were a little bit concerned, and the Director of Public Health can give us some advice on this, we were a little bit concerned that if we just did nothing and just allowed these reserves to go up and up and up, eventually government might turn around and say, oop, you're not spending all your money, maybe you don't need as much. The Director of Public Health can say if that was a reasonable fear or not. But regardless of that, the fact is we've budgeted for this spend on public health, and we should be spending the money on public health. So my question, and it's a challenge really to you, Chairman, more than anyone else, although I did raise it at the spokes meeting. My challenge is, when will you start the process of considering how we may utilise the reserve which is being built up, which I reckon is going to be approaching £3 million by this time next year? When are we going to start the process of considering what we're going to do with that money, how quickly we're going to do it with that money, and whether it should be transformative work that we do and what that should be? Thank you.
I will answer that. I won't get Jody to answer it this morning because of the time reasons, but I know what you said has been heard, and I will answer that. Any other members? Yes, Councillor Wilson.
Could I just ask a question about the savings tracker on page 137? It's good to see for adults and health that the majority of proposals are green, but there is one which is red on the Adults Positive Challenge programme relating to demand management, and it does relate to the pandemic continuing to impact on delivery of this saving. I just wonder whether there's anything more that we can hear, and whether there's anything we should be doing about it, as it seems quite a lot of money. Thank you.
No one else? Just a couple of words from me then. One is, I think, excellent report, very important for us to absorb and think about. Nothing in there that really jumped out and said we've got to decide to do something different today. I think the things that we would hope and expect to happen are happening from our officers, so I will say that. In direct response to Councillor Bowden, I promise you that we are having those discussions with the Director of Public Health and her colleagues already, unprompted, but welcome his prompting. I'm satisfied from those conversations that COVID is stopping us doing some things we want to do. Partly the staff that we've got, bearing in mind what Councillor van der Ven said, somewhat depleted in some instances, but they are absolutely focused on COVID, as we can all imagine, and probably all support. And that is holding back what we can do on other public health areas, and it's just a fact of life at the moment. But the point is a good point, and that doesn't mean I disagree with it whatsoever. You know, we don't want that reserve to build any more than it has. But I'm absolutely myself persuaded that everything that can be done is being done, bearing in mind COVID, and it's not the only area, of course, in this authority that one would say that about. Justine, to all the points, do you mind if I may progress now, Councillor Bowden? Justine, if you could respond not just to my points, but to all the points you've heard, please.
Okay, thank you. So yes, just on that one point in terms of public health reserves, Jyoti and I are discussing that anyway on an ongoing basis, looking at what is possible and what's not in terms of spending that. In terms of the reablement saving that Councillor Wilson asked about, the way that we rate them red, it sits in that red block because at the time that we looked at it at the end of July, there was a shortfall in the saving by just over 19%. And 19% is the cut-off for red, and it was 19.67. But we've been doing more work on that recently, and we are seeing numbers of the sort of work going up higher now. So I expect that won't be red by the time we look at the next quarter's reporting at the end of September. But it was the impact of COVID on the ability of those workers to do the sort of business as usual work that they would do because COVID was diverting them. So it is actually a saving that was in last year's business plan that we brought forward to this year because of the impact of COVID, and we're just tracking it until we've got to the position where we need to be. But it does certainly now look, from the recent work we've been doing, like we are definitely moving in the right direction now.
Thank you. The recommendations are that we review and comment on the report, and that we have done that. Everyone happy with that? No, there is a point. Councillor Bowden.
Sorry, Chairman. Just to make clear, I did mention what I thought the likely level of the reserve would be for public health in a year's time, deliberately because I fully appreciate the public health are concentrating still on the COVID issue. And it is something which is not going to go away. If anything, it's going to increase as far as both the problem and the opportunity is concerned. And I think it would be appropriate for this committee to be involved. And it was done previously on a very cross-party basis. I would hope it would be done so again.
So maybe in the finance monitoring report in our next ordinary meeting, not the special meeting that we're having, if that could be addressed within that report, that would be great. With that, the recommendation to review and the comment on the report, is everyone agreed? Yeah. Anyone against? That's unanimous. Thank you very much. Now, as we said at the start, Justine, you might not have been with us, but we said we would take the business planning proposals report as read, because we're going to have a whole dedicated meeting on the 14th of October just on it. So what I'm going to do is simply say, do any members have any short questions about a fact about the contents of the report, and then I promise you we'll come back and have a very substantive debate in less than a month's time on this. We're not closing down the debate at all, but trying to do it justice. Are there any quick questions of fact or understanding that people want to put about that report? I'm looking around, I don't see any. So the report is, the recommendations are to note the overview and context provided by the 2022-23 business plan, and to make any comments, which we haven't. Is that okay with everyone? Everyone agreed? Yeah, anyone against? That is agreed. Justine, if you've come along with a whole long presentation, I'm sorry, but you do get to use it next month, so it won't be wasted. Thank you very much indeed. The next item is 12, the update on the completed procurement of additional nursing and residential bed capacity in care homes. I'm particularly proud of this one. I think it's a great one. pages 157 to 162 on the agenda pack. And Joe Melvin, Commissioner, once we've done the COVID safety, we'll just check that everyone's happy that everything is properly cleaned and safe. We have. And so I invite Joe, thanks for being here. Can you address the committee, please?
Thanks, everybody. So in the wake of the COVID pandemic last year, the council launched a procurement to secure additional care home beds. The tender has been the most successful one we've had to date and secured for us 565 new block beds across 33 care homes in the county. The procurement will provide long-term investment into local care homes and will help to maintain the stability of the local care home market. And this means that local people, whether council funded or privately funded, will continue to have access to a wide choice of high quality, affordable care home provision in their local area.
Brilliantly concise, but also very good for value within that, I tell you. 565 extra care home beds and helping the care homes when they needed it, expanding the provision, but they're getting a better rate, so providing better value for money. I'm very, very pleased with this one. Any questions or comments? Councillor Bowden.
Thank you, Chairman. I'm a bit surprised to hear you say you're very pleased with this report. First of all, as far as it goes, of course, it is very good, and I welcome it, and obviously will be supporting what is being. Well, it's not a case of supporting it. I recognise what has been achieved so far as this is concerned. But what has been achieved is not what the objective was. We have failed to meet the target which was originally set, so far as this exercise was concerned. And I accept we're getting close to that target that we have before, but the target was to have a 60-40 split between block beds and spot beds, and that's not been achieved. I believe the figure is 55-45, which is good, but doesn't meet that 60-40 target. But more to the point, that 60-40 target itself has been in place for a long period of time and is very much open to challenge. And given that the size of this overall contract, we're talking in terms of the total costs, we're talking what, the best part of £500 million over the period of the procurement. Given the size of it, I'm surprised that there hasn't been stronger challenge. And I'm not just blaming the current administration. I'm surprised there hasn't been, for a long period of time, more challenge to that 60-40 target. And I understand why that you do have different requirements for different types of bed. We've got geographical concerns to take into account, and I fully understand those limitations. But given the size of this contract, I'm surprised that that 60-40 figure hasn't been more rigorously looked at least by the committee. I'm not saying what officers have done. Officers may have done a great deal of work in the background, but at least by the committee to challenge that. And when we're talking about a procurement exercise which is the best part of £500 million, these changes in percentages make a significant difference. And we have officers have limited the success that has been achieved in a number of ways. One of the limitations has been to do with price. Another limitation has been to do with geography. And so far as the geography is concerned, I just wonder whether we are unnecessarily restricting ourselves when we say that we will only be looking at homes within the boundary of Cambridgeshire itself, when we have many conurbations which, take the town of Wisbech, for example, part of Wisbech is actually in Norfolk. Now, it would make no difference at all to us if we happened to utilise a care home which was just over the border in Wisbech, and that border is very difficult to see on the ground. It would make no difference in practice, but we were limiting ourselves geographically as far as that was concerned, and we did limit ourselves as to price. And I just wonder even whether the limitation as to price has been correctly set, because if we hadn't limited ourselves, we would have been able to make additional savings, even though the marginal savings would have been less than the savings which have been achieved on what has been agreed. So these numbers are very big numbers. I welcome what has been achieved and congratulate officers on that, but we are short. We're short on the target, and that target itself hasn't been properly challenged. And I just wanted to raise those issues with you, and I'd like, subject to what I hear from the responses, I'd like potentially to make a proposed amendment to the recommendation. Thank you.
I've heard that. Any other members first? I'm sure Joe will answer that. Just from me, I think it's completely legitimate to say we should reflect on the 60-40 split. That's not been an issue that's raised to the committee before in my time. So I think that's a completely legitimate question to ask, and we'll see what the officer responds in relation to the limitations on geography and price. So we'll all listen to that. But what I'd say, if you have a tendering process, then it depends who applies and what they say in the application. It's a market-based process, whether people like it or not, it is. And so if, I would be challenging and criticising our officers if they stuck to a rigid figure on a ratio and gave some contracts that they didn't meet the quality. So I think we have to signal to our officers that the ratio is important, but that as far as we understand, a proper and fair tendering exercise has taken place. And I was very struck, I think it's 11, I apologise if I've got the number wrong, but in the report I think we've found 11 care homes that we didn't use before that we're now going to be using, which actually in Cambridgeshire terms is quite, 565 beds is great, but 11 new care homes is a very much broader base, I suppose, on which for us to offer care, and that's a very welcome development here. So although I think it's completely proper to discuss the ratio, I don't diminish the fact that I'm very happy to see these developments. I believe they have been properly challenged and scrutinised amongst the officers, and of course they're being properly challenged and scrutinised in the committee today. But I am very, very satisfied by what the outcome is. Joe.
Thank you. With regards to the split between block and spot, that figure has been developed through a number of robust discussion processes to try and find the optimum balance between block purchasing and spot purchasing for the local authority, because both types of purchasing offer benefits to the local authority as well as disadvantages. So it's almost the balance that we're trying to work forward, and that was an aspirational target that we'd like to get to, and I certainly don't think that our work in terms of developing our commissioning strategy for older people's accommodation is complete, and that will be ongoing. So in time we may well look to develop additional procurements for more block beds, or we may look to develop through some of our independent living schemes that we're looking at developing as well. So it's almost like an ongoing kind of continual process. It is important to note, obviously, we did get over 800 beds offered to us, but we were able to reject a number of those, primarily because of quality, because of locality, or because of price. And those kind of boundaries are put in place in order to protect the best interests of the local authority and our service user groups. From a price perspective, obviously there are some very, very expensive profit-making care homes out there which may not provide the local authority and the public purse with the best value for money. So that's one of the reasons. So the ceiling prices that we put into the tender were very robustly worked through with our finance and procurement teams based on the average market prices by care type and by district. In terms of geography, obviously we do still have the opportunity to spot purchase provision outside of our county as and when we need to, but it is a customary agreement between local authorities not to block contract in other local authorities' areas, because if we were to do that, then obviously other local authorities could potentially come in and block contract in our care homes, which would then prevent us being able to place our local residents or make that available to local people in Cambridgeshire. And I think the other thing is that, again, the response we have from the market is ultimately about competition, and we have a very buoyant and dynamic self-funder market in Cambridgeshire. And that's why historically we have struggled to get the volume of block bed provision that we would ideally like to have. So although we didn't reach our aspirational target, I still would see it as a success, and sort of say that yes, there is more and ongoing work that we will do to continue to develop our block contract provision.
I'm hoping we may not have one, but I do give the opportunity for an amendment.
Thank you, Chairman. Yes, I would like to place an amendment, and the reason for doing so, and I'm very grateful for the comments which have been made, is that I'm not at all convinced that the price limit which has been placed within this procurement exercise correctly reflects the marginal advantage to us at the higher price range. And I believe that there is further marginal advantage to us at higher price ranges which we have disregarded. And given the 60-40 split, which is, I accept it's an aspirational split, but given that that hadn't been achieved, although I also congratulate officers on what they achieved, but given that 60-40 split hasn't been achieved, and it in itself would need to be looked at in terms of how challenging and how stretching that target is, that is a matter of some concern. The one thing I don't disagree with is the disregard of those applications which were made, or those responses made, where there were quality issues, and that shouldn't be a matter of dispute at all. And where there are quality issues, it is quite correct to reject any responses, regardless of anything else. So I fully accept that. But there is an issue, Chairman, as I've just been stating, and it was highlighted earlier this month, and I'm sure you saw this in the report from the Alzheimer's Society, who produced a report which showed that there's going to be a massive shortfall across the country in care homes for care home places later this decade. It's already tight, but it's going to be much greater in the future. And we've really got to be careful here that we protect our interests and the interests of our residents. And that's why I'd like to make the following amendment. And the amendment I'd like to propose, and I hope you'll accept it, in the spirit in which it's meant, is that we should, instead of noting the update provided, we should note with concern the update provided, because we should have continuing concerns about the situation that we've got so far as care bed provision is concerned in this county. And I hope you would agree with that.
Thank you. The point has been heard. Whatever happens to the amendment, the point has been heard and made. And so I won't be accepting it, but I will see if there's a seconder and we'll have a vote. We've got a seconder who is Councillor Hay. We'll go straight to the vote on that. Those in favour, please show. 3, 4, 5, 6. Those against, please show. 3, 4, 5, 6, 7, 6, 7, 8. Okay, that's lost by 6 votes to 8. But thank you for the point, and I assure you it has been heard.
Thank you for hearing it, but I would hope that there was more.
Okay, no further comment, Councillor Bowden. No further comment. The point's been heard, but we're moving on. So the substantive is that the Adults and Health Committee note the update provided. I'll take a vote again just in case there's controversy. Those in favour of that, please show. Yes, that looks like it's going to be unanimous, and it is. Thank you very much. The last substantive report, and a very good one, so I'm sorry it's come very late on the agenda, is the Customer Care Annual Report, item 13. It's on pages 163 to 196 of the agenda pack, and Liz Cook, who is our Customer Care Manager, once again with the appropriate cleaning and sanitising to make sure things are safe at the desk, is going to be joining us. Excellent report, Liz. Thank you for joining us. I invite you to present it.
Good afternoon. As advised by the Chair, I'm here to introduce the Customer Care Report for providing our annual summary of statistics relating to feedback received for the year ending 31st of March 2021. Despite the challenging year, Adult Social Care have maintained that good public administration is more important than ever, and have continued throughout the pandemic to value the feedback provided by customers and to use this to drive service improvements. We encourage early resolution to complaints and support staff to deal with the matter promptly wherever possible. However, whether categorised as formal or informal, the feedback received provides valuable insights into service areas, early warning signs of problems and is a key source of information for governance, audit, risk and scrutiny functions. We continue to focus on the outcomes of complaints and what can be learned from them. Where there is some form of fault in the Council's actions which have caused an injustice, this is accepted and appropriate ways are found to put things right, and the customer care team will assist in monitoring their compliance. In summary, I hope that this report provides assurance that adult social care continue to be both receptive and reactive to the feedback received from the service user and their representatives, which continues to assist in the implementation of service improvements. Thank you.
Great. We know what a lot of work has gone into this report. It's obvious reading it, so thank you for presenting it. Members. Councillor Van der Ven.
Yeah, thank you very much for the report. Needless to say, good information and good communication is central to this realm, and I wanted to thank officers for a very efficient system from my point of view as a councillor over the years. When I've got a question about complex casework and bewilderment, the quickness of response and the triaging of questions has been just fantastic. But I was surprised that there were only 11 councillor inquiries. We need to be asking questions. We really do, and I would encourage us all to put questions forward. I mean, we also learn a great deal from the questions that are put forward. I did note at one point that we have some examples here of compliments. If I were to quote some of the complaints, sort of informal complaints that I've heard, it's really often around confusion around information, and so I've been communicating that to officers, and it's made me more aware of the constant need to review our communication and information on our website, and I know officers have been looking at that. But do please ask questions, because if we don't ask, we are representatives of people and we are encountering casework all the time, and I think questions are really valuable, so I hope we get those numbers up.
I completely agree. It really jumped off the page for me when I read that. My other comments, in addition to what Councillor Van der Ven said, I think the key element of the report is that we learn, and we learn from the mistakes. We're going to make mistakes. Things are going to go wrong, and we should have a culture of accepting that, being honest about it, and then learning from it. And I think that comes out very strongly in the report, and it should be the message from this committee back to our officers. And I was really pleased to see the very clear commitment on that. I really like the detail in sections 6 and 8, giving actual examples. You know, all of it is great in principle, but you do go into the detail in the report with the actual examples, and I think we do need to read that. And so I just congratulate you on that. If there was one thing for next year I'd like us to do, I think in the small number of cases where there's a decision of the local government social care ombudsperson, I think that the chair and vice chair should be told at the time, each time, and then perhaps bring it to committee depending on what the issue is, because I think if on those very small number of cases, it's of a level of significance that it perhaps should be drawn to members' attention earlier than the annual report. But overall, it gave me great confidence to read this report, and as I say, I know the amount of work that would have gone into it, so thank you very much. Would you like to reply to the comments, please?
Thank you. And I acknowledge what you're saying, Councillor Van der Ven, about the councillor inquiries. And I think by way of explanation is historically the customer care team don't always deal with the councillor inquiries. They go straight to team managers who can have sort of direct communication with you to speed the process up. So what you're seeing through our report is probably, you know, a small proportion of actually the communication that might be going on directly with the teams. So that might account for the numbers being slightly lower than you're expecting, potentially. And in terms of the communication, Chair, that you were mentioning about how that sort of leads to a lot of feedback in terms of poor communication in a variety of ways. There's a lot, as you say, that's going on to develop the website for information to be more easily accessible to members of the public and for them to understand more about the service as a whole, or the services that they need to access, really. So we're hoping very much that that's led to some service improvements.
Thank you very much. The recommendations are that we have noted and commented on the annual adult social care customer care report, and that we agreed to publish the report on our website. It says either. I think it's both, probably. Is it both? It's both. Right. Everyone happy with that? Yes. Just looking at nods. You're getting tired, but I have to see nods. I see them. Anyone against? No, that is agreed unanimously. Next two items I'm hoping will take as read, but of course if people want to raise things they have every right to. So 14, the agenda plan, I'm hoping to take it as read. Everyone happy with the agenda plan? They are, that's agreed. And the, hang on, another thing, don't go yet. The training plan and outside appointments. The training plan, we've already heard the point from Councillor Dupre earlier to add to that, so I just get that into the debate. And on outside bodies, we've still got a number of vacancies to fill on the following groups: the Cambridgeshire Community Services NHS Foundation Trust, we've got two vacancies, the Cambridgeshire and Peterborough NHS Foundation Trust Liaison Group, and the Clinical Commissioning Group and Cambridgeshire Health Watch Liaison Group, where we have 1 and 3 vacancies respectively. I really appeal to members. We have got representation, these things are happening, but across party I appeal to members to consider whether you might want to take up one of those vacancies. But we have concluded that the remit of the Care Suites reference group has been concluded, so that group is no longer required. But I think if you want to fill one of the vacancies, speak with Tamar, speak with Susan, who's very good at recruiting people, as I've seen, or with me outside of the actual meeting. Having said that, is the training plan and the position on outside appointments, are they both agreed? There is a point here, Councillor Bowden.
Thank you, Chairman. Apologies for adding an extra point. I'm a little bit concerned to hear that it's your opinion that the remit of the Care Suites reference group has been completed. The Care Suites initiative is an extremely important one so far as this council is concerned on the adult social care side. And my understanding was that group wasn't merely considering one particular building, but was also considering how that might be extended out elsewhere. And I'd just be interested, I'm not asking for a lengthy answer from you now, but could you circulate the committee, please, with your understanding of why you believe the remit has been completed, given that there is still so much to be done in that area and it's so important for the work of the adult side of adults and health?
I'd rather just speak directly, because it's obviously a fair question. We want member involvement in all sorts of things that this committee does or oversees. And all of them are important in my view, not just that particular initiative. So we should have a continuous view about where we want to set up task groups or task forces, but we've reached a point in terms of Ely and Princess of Wales approach where that project is going. Just wait. So to simply have one on the Care Suite, so-called, I hate those words, but I like what they do, but I don't like the words, seems to be disproportionate when there are other elements, as we've been hearing all through the morning, of our services which are important. And this committee, of course, is the prime way that we have member involvement. So setting up committees and subcommittees and task forces and working groups, and taking our officer time to then service them, we should be careful about doing that, and it's in that respect that I hope that adequately answers what Councillor Bowden has said. Really quickly,
I was just going to say, I know I expressed interest at the last meeting. I then got in touch with Mr. Singh to make a couple of suggestions. He responded very promptly, and that is my experience with officers, that if we have something to contribute or something to ask, that is maybe the best way in which we can help them at their convenience, shall I say. I will be keeping an eye on how that particular scheme progresses, but I'm sure there are other ways of doing it than just full committee.
I will allow you to come back, but very quickly, Councillor Bowden.
Thank you, Chairman. I have a great deal of confidence in the work done by Mr. Singh, I have to say, and I find him to be an extremely professional and extremely responsive officer, so I don't have any problem as far as the comments made by Councillor Slatter are concerned. But, Chairman, you said that everything we do is important. Well, that may be true, but some things are more important than others, both in financial terms and in terms of the effect it has on individuals' lives. And in terms of both finance and quality of life for individuals, there aren't many things that we are doing, many initiatives we're taking, which are going to be more important than the rolling out of care suites and managing to get that wider across the whole of the county. And I'm disappointed to hear you say that because everything's important, we shouldn't prioritise anything. I'd suggest that you just give it a bit more thought. I'm not asking you to respond now, but please just give it a bit more thought, especially when you look at the financial effects and the effects on the individuals concerned as well, potentially in the future. Thank you.
You've asked me to not respond and to keep it under consideration. That's a very fair request, of course. Having said that, do we agree the report and the training plan and the outside appointments on outside bodies and advisory groups?
Yes.
I haven't seen nods on to my right. Yes, I am seeing nods to my right. So that is agreed. Anyone against? That is agreed. I failed the Councillor Dupre test. I'll just put that out there. But we'd still have 45 minutes for our lunch, I believe, if your clock is 3 minutes slow. Because health service colleagues are joining us remotely and to a timetable, please try and be back here at 2 p.m. promptly. And I want lots of questions this afternoon, folks. We've got some really important partners with us and a really good opportunity to scrutinise the people that we're with, but that does depend on members actually participating. So come back fired up and refreshed at 2 o'clock for what is a very important further session of this committee. Thanks to everyone for this morning. See you at 2 o'clock.